2024. I would like to thank everyone for joining us today. The organizing committee of The Mantra 2024 has a great pleasure in extending a warm welcome to our conference commemorating a World Diabetes Day. Now I welcome Dr. A. Nadarajan sir to give a welcome speech and introduce the speaker.
The Mantra 2024. Our goal is to bridge the gap between the professional and fast understanding of new discoveries and shine spotlight on the innovations that will shape the future healthcare. While rapid pace of medical change in the science dazzles us, collaboration like this truly drive changes. The discussion we engage in and the knowledge we exchange will resonate far beyond the walls, and let this conference be where our aspirations for healthier tomorrow. Come, let us join the empowerment of knowledge on diabetics. Now I welcome Dr. G. Vijay Kumar for the first industry talk on GLP receptor agonist. We know he doesn't require any introduction. He's a diabetologist in Apollo Specialty Hospital, organizing secretary 50th RSSDA, which was a grand success, and he presented over 30 papers, and he has been executive committee member currently RSSDA in Tamil Nadu chapter, and he's been organizing secretary of 3D conference and former Senate member of Tamil Nadu Medical University. I welcome Dr. G. Vijay Kumar. Please, sir. Over to you, sir.
Thank you. Good morning, everybody, and then thank you for coming so early of the day, and thanks to the Mantra, the whole organization committee, scientific committee chair, Dr. Vrindaman, Natarajan, Dhanamitran, and all my friends here. So, good morning to you all. Today it's an industry talk actually sponsored by Novo Nordisk company. And it's basically how we can use the GLP-1 receptor analogs, especially the oral preparation, and how is it can help us in treating our type 2 diabetic and achieve what we wanted to have, the goals that we are supposed to have. Now if you look at going through the agenda that I would like to go into, is that decoding the trinity. See, basically the obesity, I'll discuss about that very shortly about the importance of looking into obesity, the incidence and prevalence of obesity. In fact, there is now India, they have started a obesity Association of India actually, and they're going to have a meeting in Ahmedabad next month, 14th and 15th of December. So it is taking a big place because of the obesity that is increasing. So let us look into the decoding the trinity of obesity. That is number one. And again, we can see that how established guidelines can help us where to use the GLP-1 receptor analogs, because basically they reduce the cardiovascular morbidity and reduction in weight is possible, apart from though it's being a good anti-diabetic drug. And the evidence that comes from Pioneer studies, especially I'm going to discuss about Pioneer 6, and then also how to go ahead with after getting convinced that semaglutide oral is going to be a good choice that we can think about. Now looking into the trinity, you could see that this is a common soil hypothesis. You could see that whenever you see a diabetic, there will be obesity. Whenever there is obesity, there is a diabetic, and combined we will have CVD, right? Now let us look into more interesting. About 30% of the obese people will have diabetes. Only 30%. Why? But whereas if you see that amongst type 2 diabetic, close to 90% are either overweight or obese. See the difference between the two. The reason is that why this happens is that in this why only 30% of the people have type 2 diabetes and obesity is because they have enough beta cells. In spite of insulin resistance, they have enough beta cells, that's why it's able to compensate. And that is the reason they don't develop hyperglycemia. But whereas those people who already developed hyperglycemia, you can see that close to 90% are either overweight or obesity. This is the fact that we can see that. Now, we'll be having a doubt about, we don't see in India, we don't see so many obese people in our type 2 diabetic patients, but we have a different phenotype. It's called thin fat Indian. We have more of abdominal obesity, waist circumference is higher, and then it is also established with ectopic fat around the viscera, and that causes more insulin resistance and insulin beta cell damage as well. That's the reason. We don't see much about that. But still, we have a more metabolically obese people. BMI may not be very high, waist circumference is very, very high. So that is one of the reasons you can see that. Now, if you look into that, the amount of CVD in diabetes that can happen, if you could see that, the 32% of people with type 2 diabetes have CVD. That is 1/3 of the population established CVD. And there are studies in Indian clinics where they have found that by investigating, they found asymptomatic CVD in another 1/3%. So almost 2/3 persons are supposed to be having ASCVD or CVD could be there. And if you can see the deaths that happen, though it is written as 50%, all of us know that 75 to 80% of the deaths that happen in diabetes is because of macrovascular disease. That's we know. And then here is one more statement that you can see then under it. 30% of the people with CVD have diabetes. In fact, it is underrepresented, frankly speaking. The Dr. Ramchandran, Dr. Satyamurthy study, which was done about 20 years ago, they investigated those people who were admitted in Apollo with ACS, acute coronary syndrome. They found 75% of the people had dysglycemia, if not established diabetes, first time detected. So that is amount of the relationship between the common hypothesis what we talk about. Now, if you look into that, look into the BMI, more obese people, whether you have diabetes or not, 2/3 of the people will die because of CV causes. Again, establishing that obesity is a big issue. And then 80% of the people with CAD are living with overweight or obesity. Look at this. So you can see that 2/3 of the people die because of obesity, CV causes. And those people who got CVD, they have 80% of them overweight or diabetes. Like you can see that in the top, you can see that 90% of the people are in type 2 diabetes and obesity. You look at this. And that is the reason, if you can see that about 20 years ago, Hafner has indicated, Hafner et al., they have given a fantastic statement. Mere presence of diabetes is equivalent to myocardial infarction or CV disease. Mere presence. You can see that if you look into that after 20 years, we get so much of information about the establishment of the disease and its conditions. Probably he is right. What he said is right. There's a lot of discussion about that. Now, how do we address this? Address this, the so-called CRM, that is cardiorenal metabolic disease, CRM, basically with a background of obesity. You could see that one thing is that lifestyle modification, that is very much, whether you are obese or non-obese, it's essential. And evaluation for CVD and CKD is very, very important because they are interrelated. And weight management is a big thing that we can see. That the moment they lose weight, you can see that we can have better achieve control also. 15% of the weight reduction in the first 5 years of type 2 diabetes, you can have remission as well. So weight management is a big, big, big thing. And then you can see that blood pressure control, lipid management, glycemic management, all comprehensively we need to do that all we know. But look at this, the guidelines that what they suggest. Guidelines recommend treatment with medications with proven CV benefits and CKD benefits. The moment you have CV benefit, CKD benefit is also there. You have CKD benefit, automatically CV benefit also is possible. Because they are interrelated, common soil hypothesis again. Now, let us look into what the guidelines say. What the guidelines say for us. Look at this, guidelines. Both people who have ASCVD, established ASCVD, or having high risk for ASCVD, the molecules that have been suggested are either GLP-1 receptor analogs or SGLT inhibitors. All of us know about that. There is nothing new about that. Now, if you have heart failure, it is going to be SGLT inhibitor. And if you look into the CKD, what they have said is that you got a CKD, the drug of choice is SGLT inhibitor. If you are unable to tolerate SGLT inhibitor, then think about GLP-1 receptor analogs. About 15% to 20% of the people, they don't tolerate SGLT inhibitor because of various issues that we have. So in that situation, to reduce the CKD, go for GLP-1 receptor analogs. That's the one what I said. And then efficacy-wise, efficacy and weight management, there are other two things. If you want to have an efficacy, sulfonylureas, insulin, GLP-1 receptor analogs. Moderately, DPP-4 inhibitors, SGLT inhibitors. good glycemic control. Along with weight management, if you see that, there are only two molecules that we have. Good glycemic control, weight management, GLP-1 receptor analogs and SGLT1. This is how guidelines are established. Now, just look into I will not go through that, the paucity of time. What is that? That this is a comprehensive management and in the baseline of lifestyle modification, all the establishment have to use. But what we would like to say is that look at the 11.4C, you can see that those people who got established cardiovascular disease and CKD, the drug of choice is combination of GLP-1 receptor and SGLT inhibitor. This is how we need to think about that. It's a very good combination that we can think about. Now, why GLP-1 receptor analogs? We can see that we have ominous octet, right? Ominous octet. Except for increased lipolysis and increased glucose reabsorption, the two things, directly or indirectly, other 6 ominous octet principles can be taken care of by GLP-1 receptor analogs. So, almost majority of the pathophysiological factors, because today the philosophy of management of type 2 diabetes is not addressing the hyperglycemia, it is addressing the pathophysiological factors that cause hyperglycemia. So, we need to look into that. Now, what multifactorial approach for GLP-1 addressing all the components of the trinity, like reduction in HbA1c, reduction in weight, reduction in blood pressure, reduction in lipids as well. I will show the evidence to that. Reduction in inflammatory markers and CV benefits also can be there. Now, why semaglutide? There are certain points that we can think about. If compared to, say for example, dulaglutide, if you see that, definitely you got a better weight reduction with either sema or lira. That is number one. And the most important thing is that the homology. It's a human GLP homology is 90% with semaglutide. There are 2 amino acids that are changed in that, and then you can see that they got a SNAC, that is a lipid component which reduces the absorption or degeneration of the amino acid chain in the gastric system. So you can see that it's got a 90% homology is possible in that. Now, there are some, I think there is some, you can see that this is called as the SNAC. This is absorption enhancer. This is called as the SNAC. That is, basically it improves the availability. Otherwise, if you don't have the SNAC, when you take orally, amino acids are digested. So that is the reason you can think about that. Now, if you can see that, a more important thing is that it is only that approximately only 1% of the semaglutide is absorbed, the rest is degraded in the GI tract still, in spite of the SNAC. This one absorption will give so much of benefit that we can think about. Now, what are the benefits? What are the evidences that we have that it established? We can see that Pioneer 1 to Pioneer 8 we have. Pioneer 1 is basically diet and exercise compared to placebo, basic. Pioneer 2, you see that it is versus SGLT inhibitors with or without metformin. Pioneer 3 is compared with DPP-4 inhibitors with metformin and sulfonylurea. And then Pioneer 4 is with placebo along with standard of care, either DPP-4 inhibitor as metformin and SGLT inhibitor. And Pioneer 5 is basically in the renal impairment. Pioneer 6 is the one which has got a CV safety. It's not a CVOT trial. It is a CV safety establishment study. And then 7 is that flexible dose adjustment DPP-4 with extension. And then Pioneer 8 is with insulin. So I think if you can see that the evidence that has been collected is very broad-based. That's what you should say. Now let us look into, we'll not look into many things, but one thing what we can look into this, whatever category of Pioneer, with various molecules associated with their molecules, there is a further HbA1c reduction of 1.2. This is very powerful. Number one. Number two, look at by adding a semaglutide oral, you could see that you will get up to 50 kg weight reduction further in spite of having SGLT inhibitor. That is number two. Now, if you look at the CV safety, if you can see that, it has compared to placebo, the MACE reduction is about 21%. which is non-inferior. If not, it is not achieve the superiority over placebo, but non-inferiority has been definitely established. And so that you can see that there is a 21% non-significant risk reduction versus placebo. The more important thing is CV safety, primary outcome, that is CV death, non-fatal MI or non-fatal stroke, that is MACE, is established statistically significant. So safety is established, number one. And apart from that, if you look into the population that has been included, more than 50 years of age with established cardiovascular disease, if they are more than 60 years, at least one CV risk factor will be there. And then HbA1c and body weight reduction is significantly reduced, very clinically significant, and high retention rate. Now 19, almost close to 100% of the people were retained in the study. There is no dropouts. That is most important that we need to think about. So it is 21% non-significant risk reduction with placebo. This is basically a CV safety trial. We will look into that other one. There is also a CV OT trial is also possible. Now, as I said that it not only reduces the weight and HbA1c, it also reduces the blood pressure, it reduces inflammation. Look at the waist circumference. That is what is most important for Indian population. That is, the waist circumference is reduced and lipid profile also is established. Now, look at the waist circumference. Empagliflozin is, that is, SGLT inhibitors will reduce the waist circumference. But compared to even SGLT inhibitors such as EMPA, there is further waist circumference reduction when you use semaglutide. It's very nice. Now, almost minus 4.7 centimeters of waist circumference reduction. This is very, very good actually. And then you can do that. The most important thing is that energy intake. It works on the satiety center and reduce the energy intake by 35%. So if you reduce energy intake by 35%, that is very good for weight reduction as well. In fact, it is also said that these things will reduce the taste for your favorite foods otherwise. So that's another important thing. Now it reduces systolic blood pressure. It reduces the lipids, especially the Indian phenotype of triglycerides. You can see that there is an establishment triglycerides like what we see with SGLT inhibitors. We can see that there is the triglyceride reduction, and also SGLT inhibitors will increase LDL slightly. But whereas this is the difference between that. There is a reduction in semaglutide. We can see the reduction in LDL as well. Now this hsCRP, the inflammation, is reduced compared to empagliflozin also is reduced, but it is almost 3 to 4 times more reduction with oral semaglutide. So markers are reduced. Now that you are convinced that it is not only a good glycemic control, weight reduction, but all other benefits as well, you can see that. Now let us chart out the so mechanistic. Suppose you combine SGLT inhibitors, GLP-1 receptor analogs, the benefits that you are going to get are going to be extremely well, because we know that the benefits that we can think about SGLT inhibitors and combined with both have got a common things a lot, except for that heart failure advantage with SGLT inhibitors. Heart failure extra advantage is there. So there is the MACE reduction in both SGLT inhibitors as well as GLP-1 receptor analogs. So that CV protection, CV reduction, CV death reduction with both the molecules, if you combine, it is going to be a great use for people in future. So we can see that the good glycemic control, we know that, we think about the residual risk reduction only when you use the statins, right? Statins, we say that about 35% to 40% risk reduction, 60% risk reduction, residual risk will be still there. Similarly, having a comprehensive management of diabetes, that lipids, glycemic control, blood pressure, but there is still residual risk. To address the residual risk, I think the combination of GLP-1 receptor analogs such as oral semaglutide along with SGLT inhibitors is a good choice that you can think about. That is number one. Better mitochondrial salvage post-MI. Reduction in risk for EGFR decreased by more than 50%, that is kidney protection. MACE and all-cause death can be reduced by combination. Lower risk of end-stage renal disease possibility is very, very low, and more CVD-free life years. That's the most important thing. Now, remember the Pioneer 6 we thought about cardiovascular safety, but this is a SOUL study which is about 9,600, which is basically a CVOT trial, where the key endpoints primary is at MACE reduction, and secondary so many points are there. And then you can see that there are about 800 patients from India included in this 9,600 patients, 800%. The top line results, the total results are not yet out, but the top line results yesterday we got it about SOUL is that there is 18% reduction in MACE. That's a good news. This is CVOT trial, 18% reduction. This is not yet come. These are top line results that have been established. So MACE reduction by 18%. So the SOUL study, and then there is one more study which is going to come with Indian real world data, where real world evidence on oral semaglutide, because RCTs are different and real world data is different. In fact, at least in India, in fact, me and Dr. Nalla Perumal are speaking about before the talk, the real world Indians, people respond better to the molecules what we see in RCTs in other populations like Caucasian population and blacks. So we respond better. And probably that is the reason they had a real world evidence of oral semaglutide. What they have found is that HbA1c, based on HbA1c is almost close to 9, and 90% was started with achieving better glycemic and weight management. And 1 in 5 were started on oral semaglutide within 1 year of diagnosis. And then 1 in 2 participants had CVD. That's almost 50% of them have got a CVD related history, stressing the need for effective treatment options. The results are not yet out. We'll be getting shortly the results. Thank you for your patient hearing.
Thank you so much for the session, sir. And once again, I would like to thank everyone for joining us today. Welcome to D Mantra 2024. Advancement in the field of medicine have always been a testament to human determination, creativity, and inner desire to heal and improve lives. Today, as we gather at this event, the essence of welcome speech at the medical conference, a set of tone, groundbreaking discussion and collaboration. Now, I would welcome Dr. P. Parandaman sir to give a welcome address.
Just welcome. Very good morning to all present here. On behalf of D Club and D Mantra 2024, my hearty welcomes to all of you for this conference, and I extend my welcome to our professors, mentors, gurus, sitting over here, Professor Venkatraman, Professor Swami Kanna sir, and Professor Nalla Perumal, and Dr. You listen to Dr. Vijay Kumar sir, and all our senior professors here, and welcome all the delegates for the topics are lined up in concurrence with World Diabetic Day theme, that is diabetes and well-being. Well-being, physical, mental, and social well-being. So all the speakers have selected, very excellent. You will be enjoying the academic feast over entire day. I welcome you again for this conference. Thank you very much.
Thank you so much for the wonderful words, sir. Now we can start the scientific session. We would love to have the chairperson for this session on the stage, Dr. M. Swamikanna sir and Dr. A. Natarajan sir. Dr. M. Swamikanna sir is a senior consultant HOD of MGM Hospital, and Dr. A. Natarajan sir is a consultant diabetologist at his own center in Anna Nagar, Chennai. Now, and the speaker of this session, Dr. S. Nalla Perumal sir, who will talk on the diabetes in 2 generations, mother and child. Dr. S. Nalla Perumal sir is a consultant in pregnancy diabetes at Prasan Hospital and MGM Motherhood Swami Diabetes Center.
Shall I say? Yeah. Good morning, everyone, and thanks for the D Club organizers for having given me this opportunity to share my views on this important topic. We listened to Dr. GVK sir about treating diabetes so that we can prevent people from getting into micro and macrovascular complication. We are going to go a little upstream because a mother nourishes her baby during her pregnancy. herself and the baby, fetus. Then during the first 2 years of life, the infant, toddler is being fed by the mother. And obviously the way she is going to nourish the baby and the child is going to play a vital role in whether we are going to develop problems in the future. So the kind of nutrition, the first 1,000 days makes a difference in the rest of your life. Pregnancy is about 270 days. First year, second year, and all put together is 1,000 days. This is going to be the important period. And we all know the first 2 years, the brain develops fast. There are other organs like thymus, which are going in a very rapid phase. And there is high degree of plasticity. See whether these developing tissues, very sensitive tissues, are going to expose to some triggers, whether it is through nutrients, whether it is due to other stressors, that is going to play a vital role in how these organs are going to behave in your adult life. And this is diffusion MRI, you can see there. And the first 2 years, the tissues are very, very sensitive. They are very plastic. On the right end, you can see the brain cells in the newborn. At 1 month, there are about 10,000 cells. Within 6 months, it becomes 10 billion cells. Just imagine how rapid the growth is happening and how nutrition is going to be very, very important during this phase of the life. So for disease prevention, obviously, timely intervention is very important. This timely intervention should start from the mother, so that if we can address the maternal and infant nutrition early on, then you are going to prevent the impact of future diseases. That is going to be very, very small. So all of us are going to get aged, all of us are going to develop cardiovascular disease at some point. But it need not be earlier if we address the nutrition of the mother from the start. So before moving on to this presentation, there are few things which we need to understand about epigenetics. All cells in the body are derived from a single cell, that is zygote. Every nucleated cell in the body contains the same DNA sequence which carries the organism's entire genome. Despite having the same genetic code, the cells from different tissues perform different functions due to different gene expression. So epigenetic regulation that can increase or decrease the expression of genes also contributes to this cell type specific phenotypes. An epigenetic modification is a chemical alteration to DNA or chromatin that does not affect the primary DNA sequence. That means the primary DNA sequence remains intact throughout our life, only the epigenetic alterations that happen. So epigenetic changes are heritable, and conditions that might alter epigenetic changes could include all the disease states. I mean, the way the mother got exposed during her pregnancy, whether she goes through a famine or she is exposed to toxins, chemicals, drugs or viruses. So all that is going to do some epigenetic changes which include histone modification, DNA methylation, as well as microRNA based changes. So these prenatal and postnatal exposures cause epigenetic changes that may last even for generation. There could be an intergenerational transmission of these changes. So even up to 3 generations it can get transmitted. So these are the possible stressors, folic acid deficiency, whether the mom is taking adequate quantities of fish oil, whether she is stressed during pregnancy, whether she is obese to start with, whether she smokes during pregnancy, even air pollution. So the way she is going to consume her food, everything is going to alter the epigenetic modification of DNA. So the timing and duration of exposure are also critically important. So whether it is the exposure happens during the intrauterine life, or both intrauterine as well as postnatal exposure, or only during postnatal exposure. So there is contribution between from the nurture as well as nature also. So we'll first start with intrauterine exposure. So this is a Dutch famine cohort. So in 1944, Nazis enforced rationing in Holland. A small part of Holland was encircled by Nazi forces. So about 1 lakh of people got caught in that area, and they had very limited food supply. So naturally they had to ration the food that is available until the siege ends. So the siege continued for about 6 to 9 months. So some mothers were pregnant. They were in the early stage, first trimester. Some mothers were in the second trimester, and some others were in the third trimester during that siege. So for 7 months, the energy intake dropped from 1,800 kilocalorie to 400 to 800 kilocalorie per day. So including pregnant mothers had rationing, and pregnant mothers delivered smaller babies. So these babies were followed up into their adulthood. That cohort is known as the Dutch winter famine cohort. And you can see there the red areas for Dutch famine, and some mothers were in the early pregnancy, some others in mid trimester and late trimester, and so on. So the effects of on infants in later life depended on which time of their intrauterine life these babies got exposed. If they got exposed during the first trimester, they developed glucose intolerance, CVD, hypertension, dyslipidemia, and obesity. If the moms got exposed during the second trimester, these babies developed glucose intolerance, pulmonary disease, and renal disease, and third trimester, glucose intolerance. And the stressors during pregnancy, even if the mom is stressed out, depressed, anxious about so many things, even marital conflict during pregnancy, that also can lead to increased weight in the mom, as well as there is a disturbance in autonomic and HPA axis dysregulation, which can lead to future life course events. So all adult metabolic diseases can be programmed in the uterus. So maternal-fetal stress factors could lead to the changes in various organs, which include kidney, pancreas, heart, liver, muscle, blood vessel, and adipocytes. And that can lead to increased risk for hypertension as well as cardiovascular diseases, type 2 diabetes as well as obesity. So this is, can any one of you name this actress? Yeah, this is Audrey Hepburn, one famous Hollywood actress. Actually, she was within that, when she was a child, she was in that sieged area of Holland. So she had very limited food supply as a child, and during her later life, she suffered due to pulmonary disease. So she had miserable life in her adult life due to that exposure, which happened during her childhood. So this is the data from India, the recent National Family Health Survey. You can see 40% of TN women are overweight or obese. So urban, rural, there is no big difference, almost 40%. And alarmingly, children under 6 months who are exclusively breastfed was only about 45 to 50%. Even in India, breastfeeding is not 100%. Okay, so this is going to play a vital role in future diseases. So this is another lay press article, Chennai women more obese, diabetic than those in other 4 metros. So this is the data from the world. Overweight and obesity in pregnant women is on the rise, and you can see India is colored red. The prevalence of overweight and obesity in pregnancy is very high in India. So we are looking at both undernourished mother as well as overnourished mother. I have shown you the data for undernourished mother from Dutch famine cohort. So now we are seeing more of overnourished mother because already they are overweight, obese, or their gestational weight gain is becoming a big problem. So overnourishment also is going to be a problem in the future. Actually, the slides are not getting projected properly. So, and this is a busy slide. So not only the glucose, we talk about diabetes in pregnancy, GDM or pre-gestational diabetes. When the mother is obese, there is more traffic of amino acids, free fatty acids. So all the substrates that can cross placenta and trigger the baby's IGF receptors and program the fetus for future diseases. So it's all about the nutrition, which is different in obese mothers. And mothers who gain a lot of weight during pregnancy also behave differently. Slides are not moving. So you can see the contribution of genetics, epigenetics, as well as whether the mom is obese, whether she has got pre-existing insulin resistance, what is her beta cell reserve, whether she has got metabolic syndrome, whether her diet is adequate or overnourished, all that is going to play a vital role for the future. So metabolic culprits in utero leads to big baby and a bigger picture. And this is IOM guideline recommendation about pregnancy weight gain, because we see a lot of pregnant mothers gaining more weight during pregnancy. So if they are already overweight or obese, we have to educate them about the need to not to gain more weight, especially during the first half of pregnancy. And the timing, again, the postnatal exposure. We have covered intrauterine exposure, we'll move on to postnatal exposure. So if genetics is your television, it's already made, the television is made, you bought the television. Epigenetics is your tuner. So the way you are going to lead your life, whether you are going to tune your life to perfect picture or not, is going to play a role. So this is again the queen bee example. So the worker bee, drone bee, queen bee are all the same. They have the genetic code. But the queen bee is allowed to take extra nourishment during the first few days of its life. So it becomes 3 times larger, live 28 times longer, and lays 2,000 eggs. The exclusive food is royal jelly, which only the queen bee is allowed to eat. So that shows the early nutrition, how it is making a big difference in the difference between the queen bee and the worker bee. So breast milk mirrors the infant protein requirements. You can see the black line is the infant requirement, and the green one is mean protein intake of breastfed infants. Actually, breast milk contains less protein and more fat. Okay, so the protein content of breast milk is about 0.9 to 1.2 grams per 100 ml. Whereas if the mom is not feeding the baby with the breast milk, if she is going for infant formula or cow's milk, you can see cow's milk is 1.8 to 2 grams of protein, and infant formula varies between 2.2 to 3 grams per 100 kilocalories per 100 ml. So the protein content of cow's milk and infant milk is on the higher side compared to breast milk, and high protein intake, especially early on, is known to increase the risk for obesity and future diabetes. So breastfeeding protects the infants. There is an early protein hypothesis. According to this, high protein intake in early infancy stimulates insulin and IGF-1 receptors, and higher number of adipocytes are there as the baby grows. So high protein intake in infancy causes faster weight gain and higher BMI in the first 2 years of life. So unbalanced nutrition is playing a big role. So if the mom is taking a high protein intake, or if the mom is restricted with fat, especially during the first few months of life of the infant, it's going to play an increased role in increasing the risk for adult obesity. And bottle feeding, again, bottle feeding is associated with weight gain, because bottle feeding, regardless of the contents, even if the mother expresses the breast milk and gives it in the bottle, that makes a difference, because the baby has to latch onto the areola, the nipple, and there are neural stimulation, there are cues for the mother as well as the baby about when to stop feeding the baby and whether it is enough for the baby. All that cues are missed. The baby gets overfed if it is fed through the bottle, and there is a rapid infant weight gain, and that can lead to obesity. And also the early diet, how the baby gets a diet. So all the children, they get sugar sweetened beverages even during early life, and they go on to continue to take or like those kind of foods. If they don't get exposed to fruits and vegetables during their early life, then they don't like these foodstuffs later in their life. So catch-up growth is also important. Babies who are born low birth weight or IUGR babies, they catch up, and then that also leads to obesity. So current pediatric obesity prevalence is very high, so we need to optimize the maternal weight, achieve metabolic control for the mother if she has got pre-gestational diabetes, and we have to always plan the pregnancy. It is better to prevent pediatric obesity than to treat it. And finally, the intrauterine and postnatal exposure together. Again, this is a nice paper from Science where they assessed the exposure of the babies during the first 1,000 days of life to sugar. So they had a good data biobank in UK. So where they assessed the sugar intake of the moms. Actually, what happened during the World War, at the end of World War, sugar was rationed. So for about 10 years, sugar and sweets rationing commenced in UK in July 1942. Rationing ended in September 1953. So once the sugar rationing ended, the sugar consumption sharply increased. Adults born or after 1st July 1954 are never exposed to rationing because they were taking ad libitum any amount of sugar. 1000-day window spans from 1st October 1951 to 30th June 1954. So duration of exposure to rationing was divided into never got exposed, in utero only, and in utero plus 6 months, plus 12 months, plus 18 months, or plus 24 months postnatally. So you can see the table on top where the first half of the picture depicts that those who got exposed to sugar, sugar rationing, their moms were not exposed to sugar during this period of the intrauterine life or first 2 years of life, and those who never got rationed, so they were taking sugar like anything. So you can see the line dividing where the sugar rationing ended. There was a sharp increase in the sugar intake. So they compared the groups whose moms got exposed to the rationing and those moms who were never exposed to rationing, and these children were followed up to 50 to 65 years of age through the biobank registry. So you can see risk of type 2 diabetes diagnosis increased faster among adults with little or no exposure to rationing. So you can see rationing up to 1000 days. That means these moms had limited amount of sugar intake during their pregnancy. Their offsprings, the risk of developing diabetes was far less than those moms who were taking sugar in a higher level. So out of 60,000 subjects, around 3,900 developed diabetes, and they assessed these people whether their moms were in which stage of pregnancy during the sugar rationing period. And again, hypertension also, the diagnosis increased faster among adults with little or no exposure to rationing. So if the mother is rationed with sugar, her sugar intake was less during intrauterine period, then naturally their offsprings developed lesser incidence of hypertension. So their risk to develop hypertension and diabetes was very less. And again, the duration of exposure to rationing also plays a role, whether it is during intrauterine life or during the first year, second year, all that plays a role. If the sugar intake increased after first year, again the risk for diabetes increased exponentially. You can see the non-ration people versus ration people. And hazard rates of type 2 diabetes, various levels of rationing exposure again is different between men and women. For women it is more. If it is a girl child, the mom is having a girl child in her uterus, then the risk for future diabetes and hypertension is less. So girl children are more vulnerable during their intrauterine exposure to the nutrients. Risk of obesity was inversely proportional to the again rationing exposure. So and the delay, even if they develop diabetes and hypertension, diabetes was delayed by about 4 years if their mom got rationed, and hypertension was delayed by 2 years if their mom got rationed during the intrauterine life. So 1000 days of opportunity is there. We should never miss it. This paper concludes that early life exposure to sugar rationing led to a reduction in type 2 diabetes and hypertension risk by 35% and 20%. Onset of these diseases is also delayed by about 4 and 2 years respectively. Risk of obesity was also reduced by rationing. Most risk reduction occurred when rationing lasted beyond age 6 months, that is 6 months to 2 years of age. Girl child seems to get more benefits from limited exposure during the first 1000 days of life. So we have seen women who got exposed to famine, women who are obese, women who are already diabetic during their pregnancy. There are a lot of epigenetic changes which could occur, which plays a vital role in the future risk. And it's all about manufacturing, transportation, and upkeep. So things can go wrong at any stage. So intrauterine life, you can compare to the plasticity of the mud. when the potter is going to create a pot. And once a pot is made, still how we are going to handle the pot is going to be important. So during early life, if the pots are handled better, then they are going to be very productive, or it's going to get broken. So finally, what needs to be done? We need to think transgenerational. A girl is a mother from the time of her own mother's conception. A mother is a biological bridge to the health of future generations. Act now. Focus on the health of young girls, mothers to be, pregnant mothers, and children 0 to 2 years. And primordial prevention is the best hope to reduce the burden of NCDs. And so with this, I end my presentation, and thanks for patient listening.
Thank you so much for the wonderful session, sir. Now I request Dr. A. Natarajan, sir, to present the memento to Dr. S. Nallapemma, sir. The speaker of this session, Dr. R. P. Rajesh, sir, who will talk on diabetes prevention and reversal. Dr. R. P. Rajesh, sir, Contalson Diabetes Ardhavan Diabetes Research Center at Kodambakam and Velachery, Chennai.
Respected chairpersons, senior clinicians, and my dear friends, a very good morning to all of you. I take this opportunity to thank the organizing team of D-Mantra for the opportunity given here. And I am going to discuss with you about prevention and reversal of diabetes. And yes, so we all know about the management of diabetes. The primary aim in managing diabetes is to prevent the complications, and we have several landmark clinical trials which have shown how to treat people with diabetes. All these trials have shown that when we want to prevent the complications for our patients, we have to be aggressive, and from when we have to be aggressive is that right from day one of diagnosis of diabetes, we have to be aggressive. And again, we do have evidences in the pre-diabetic population also, which tells us that when we are aggressive in these population, we can prevent the onset of diabetes in them. Thank you. So, I'm not going to discuss about the early aggressive treatment here, because in many forums we have discussed this. I'm going to discuss more in detail about the reversal part of diabetes, which is a relative new concept. So before going into what is reversal or what is remission, we just need to understand what is the pathogenesis which causes diabetes. We all know about the pathophysiology. There are several pathophysiological defects which is implicated in the causation of diabetes. Even if there are so many pathophysiological defects, we know that beta cell dysfunction is the primary, is the critical one. Unless there is beta cell dysfunction, we know that diabetes will not develop. So, if you look into the decline in beta cell function, it actually starts 10 to 12 years before the onset of diabetes, and from that time you can see there is a progressive decline in the beta cell function. Once there is more than 50 to 60% decline in the beta cell function, your diabetes actually manifests clinically, and it doesn't stop with that. Even after the diagnosis of diabetes, what you can see is that there is a progressive decline in the beta cell function, and which tells you that the beta cell function dysfunction is actually progressive, which happens throughout the life. So obviously type 2 diabetes is also a progressive disorder. So we are all very, very clear with these messages, and we have a very good understanding that type 2 diabetes is inevitably lifelong, because the beta cell decline in the beta cell function is obviously progressive. So our understanding is very, very clear in these concepts. But what happened after the bariatric surgery came into existence? What actually happened here is that we saw, but bariatric surgery was actually done for a different reason, for obesity. But what happened in those people, after the bariatric surgery, we saw that there was normalization of the glucose metabolism. And what was the reason? When they probed into what was the reason behind this normalization of glucose metabolism, they found that it is not because of the anatomical changes what we are making there, it is because of the sudden and profound decrease in the food intake. That is what is responsible for the reversal of diabetes in those subjects. So, having understood that, we need to understand what is reversal, what actually causes reversal. So, for understanding that, we need to understand what actually causes beta cell dysfunction. So, for this, Roy Taylor, way back in 2008, he proposed a theory called twin cycle hypothesis. What does it postulate? When there is a chronic excessive calorie intake, what happens? There is too much of accumulation of fat in the liver, which eventually gets spilled down to the pancreas, which eventually brings about pancreatic dysfunction. This is what twin cycle hypothesis tells you. If you want to go more into that, you can see what happens when somebody takes too much of calorie for a prolonged period of time. So, when there is excess calorie intake, the excess energy will actually be diverted to the liver and other ectopic tissues in the form of triglycerides. So, more and more of calorie intake, more and more of fat deposition will happen in the liver. So, when there is more and more amount of fat deposition in the liver, what happens? The hepatocytes will have a reduced responsiveness to insulin. So, thereby there will be development of hepatic insulin resistance. So, when this hepatic insulin resistance sets in, what happens? There will be failure of the insulin to switch off the hepatic gluconeogenesis. So, obviously, the hepatic glucose output will actually increase, so the blood glucose level will also increase. So, when the blood glucose level increase, what happens? This increased glucose will become a substrate for de novo lipogenesis, which primarily happens in the liver. What is this de novo lipogenesis? It is a metabolic process of converting glucose into fatty acids. So, that will again get increased here, and in the early stages patient will not be having diabetes. So, the beta cell will compensate for this hyperglycemia and produce more insulin, and what happens is that this hyperinsulinemia in fact increases the de novo lipogenesis. So, more and more amount of lipid will get deposited in the liver. So, this enhances the liver cycle. So, insulin resistance, hyperinsulinemia, de novo lipogenesis, again more deposition of lipids in the liver. So, this is what happens. So, under these circumstances, what will happen is that there will be increased export of the VLDL triglyceride from the liver into the circulation. So, the triglyceride level in the circulation will actually increase. This will favor deposition of your triglycerides in the subcutaneous tissue. But actually, when you look into the subcutaneous tissue, it is a metabolically safe area for storage of triglycerides, but the threshold for safely storing triglyceride in the subcutaneous tissue differs between individuals. So, when an individual's threshold for safely storing triglyceride in the adipose tissue exceeds that limit, what happens? It cannot store triglyceride in the subcutaneous tissue. Eventually, it gets spilled over into the pancreas. So, thereby it enhances the pancreatic cycle. What happens in the pancreatic cycle? There will be chronic exposure to, there will be too much of accumulation of fat in the pancreas. So, pancreas will get exposed to this fatty acid and also to the toxic metabolites of the lipids. Eventually, all these things will lead to pancreatic beta cell dysfunction. So, this is what happens. So, I told you about two cycles, liver cycle as well as pancreas cycle. So, all these things, what is the culprit for this? This is the chronic excessive calorie intake that only caused excessive deposition of fat in the liver and excessive deposition of fat in the pancreas. So, eventually what it implies is that the beta cell dysfunction here in this case is brought about by ectopic deposition of fat in two organs, that is liver as well as the pancreas, which in turn was due to increased calorie intake. So, this is what the twin cycle hypothesis suggests. So, having understood the pathophysiology of beta cell dysfunction in people with type 2 diabetes, now comes the question that if you are able to reduce the amount of fat deposition in the liver as well as in the pancreas. Can we reverse type 2 diabetes? So this is the question. For better understanding, I am just going to project you few clinical trials. This is the Counterpoint clinical trial, again done by Roy Taylor himself. Here he has taken 11 patients having type 2 diabetes who are all obese. You can see the BMI of them were above 35. So he has taken them, all of them had diabetes duration of less than 6 years, and what he did is that he took off all the medications from them. He stopped all the anti-diabetic medication, all of them were not on insulin. He stopped all the anti-diabetic medications in them, and he wanted to induce a good amount of weight loss. For that, he started them on an 8-week period of very low calorie diet to the tune of somewhere around 600 to 800 calories per day. So this he continued for a period of 8 weeks, and what happened is that all these patients reduced their weight by 15%. He was able to achieve 15% of weight loss in these patients, and as a result you can clearly see within a period of 1 week of starting the very low calorie diet, you can see the fasting blood sugar actually dropped down, and you can see the basal hepatic glucose output also actually came down. And what is more important, with the help of an MRI, they were able to find out from the baseline, with the help of a hypocaloric diet and weight loss, they were able to find out, they were able to show that the hepatic triglyceride content also came down in these patients. So they were able to, with the help of weight loss, they were able to reduce the hepatic deposition of lipids in these patients. So here you can see, as a result, you can see there is progressively decline in the pancreatic triglyceride content in these patients as a result of weight loss, and because of that you can see the first phase insulin response actually increased. So what it tells you is that in patients who are obese having type 2 diabetes, you achieve very good weight loss of 15% from their baseline body weight with the help of a low calorie diet for a period of 8 weeks. What happens is that you are not able to bring a good control of diabetes without the help of drugs, but you are also able to reverse the pathophysiology which caused beta cell dysfunction here. That is, you are able to reduce the liver fat content as well as the pancreatic fat content. So now we have a question here. Is this possible only for a period of 8 weeks? Whether what was achieved in the period of 8 weeks, whether it is durable or not, and what happened if the patient comes back to iso-energetic diet. So here they were taking only 600 calorie diet. What happens if the patient comes back to his normal diet? For this you have the counterbalance study again done by Roy Taylor himself. What happened here? Here there were 30 participants, all of them having type 2 diabetes, all of them were obese. I told you the BMI for these patients were also above 35, and here what happened is that he again gave hypocaloric diet to the tune of somewhere around 600 to 800 kilocalories per day for a period of 8 weeks, and after that there is a gradual return to isoenergetic diet for a next period of 6 months, which means after 600 kilocalorie diet for 8 weeks, they again came back to 1500 to 2000 kilocalories per day of diet. So what happened in these patients? Here you can see the fasting plasma glucose dropped substantially. There were two groups of patients. One were responders and the other one were non-responders. Among the responders, you can see the plasma glucose dropped down significantly and was maintained over a period of 6 months, and again the HbA1c also dropped within a period of 8 weeks, maintained over a period of 8 weeks, and the weight also dropped here equally. Both the responders and the non-responders, they all had 15%, close to 15% of weight loss. So again you can see the hepatic triglyceride content also came down, as well as the pancreatic lipid levels also came down, and the first phase insulin response also increased in patients who were responders. But there are also a small set of patients who are all non-responders. Who are they? If you look into their profile, all these non-responders had longer duration of diabetes. The responders had duration of diabetes was less than 8 years, but the non-responders had a higher duration of diabetes, that is 8 years to 15 years. So that's the reason. So when you are going to aggressively treat our patient, when you are going to target them early in the course of diabetes, this is possible and this is durable also. That's what we are getting from the counterbalance trial. Now having understood these things, let us just look into what exactly we mean by reversal or remission of diabetes. Sorry. So what do we mean by this? So both are, the term reversal as well as remission are often used interchangeably, but there are subtle differences between these two terms. When you say it is remission, it implies that patient is able to maintain a normal HbA1c without the use of any anti-diabetic drug for a substantial period of time, that we will see subsequently. But when you say reversal, here they are able to maintain normal HbA1c but need not be always off the drug. If the patient is on insulin with multiple oral drugs, just stopping away insulin and continuing the oral drugs also can be termed as reversal. Or if the patient is on 4 classes of oral drugs, if you are able to reduce it to 2 classes of oral drugs, that also can be said as reversal. But ultimately they are used interchangeably, but what we are more comfortable is with remission, and ADA gives 3 mutually exclusive states of remission. One is complete remission. What it is? The HbA1c drops down to non-diabetic range, that is HbA1c will become less than 5.7%, and the fasting also will drop down to non-diabetic range, that is less than 100 milligrams per deciliter, at least for a period of 1 year. If this continues for a period of more than 5 years, we call it as prolonged remission. Or if the HbA1c as well as in the fasting blood glucose level remains in the pre-diabetic range, that is between 5.7 to 6.5 and between 100 to 125, then that is called partial remission. So this is what. Now the question is, what causes remission or reversal in these patients? Very, very simple, very, very straightforward. It is simply weight loss, weight loss, weight loss. Only the weight loss brings about the remission in these patients. And again, now comes the other question. So we have seen that it is possible, the remission is possible, we have seen that remission is durable, but is it possible to achieve in our clinical setup? Are there any data, are there any real world data to support this? Yes, you have something called as the direct trial, which again was done by Roy Taylor. Here you can see there is more number of people, around 298 people were enrolled. They were enrolled into 2 groups, they were divided into 2 groups. One was the interventional group, the other one was the control group. In the interventional group, what they did was that they gave hypocaloric diet for a period of 3 to 5 months. It is not 8 weeks, it is 3 to 5 months. And after that, over the next period of few months, what they did was that they gradually reintroduced to the isoenergetic diet, and they followed these patients at 1 year as well as at 2 years, and you can see the result. They also achieved more good amount of weight loss, and you can see if the patient achieved more than 10 kg of weight loss, you can see 57% remission rate was there. But if it is more than 15 kg, you can see 86% remission, or if it is more than 10 kg itself, you can see 73% of these patients got remitted. But in the control group, only 4% of the patients were able to achieve remission. So this tells you what amount of weight loss will bring about good amount of remission. So again, the role of exercise also has to we need to understand, because all these weight loss can involve some amount of muscle loss also. So to prevent the sarcopenia, what we need to get, we need to have adequate protein intake, as well as we have to do resistant exercise. I am not going into those details. Again, bariatric surgery also can bring about this amount of weight loss. We can see in so many clinical trials, after doing bariatric surgery, they achieved substantial amount of weight loss to the tune of 15% from their baseline body weight, and they were able to remit their diabetes. And by doing so, you can see there is reduction of microvascular and macrovascular complication also. I am not going into these details. But now comes the main question. So are we able to see, so long we were giving clinical trials where they involved people having higher BMI. All of these patients' BMI was more than 35. But now comes the question, in patients who have a normal BMI, is it possible to achieve remission by achieving good amount of weight loss? Because conventionally we have been taught that the pathophysiology which is causing diabetes in patients who are lean and who are not obese are completely different. This is what our conventional thought, and most of the guidelines do not recommend weight loss for patients who are lean. So in this context, if you are going to, if we can bring about weight loss in patients who are non-obese, are we able to achieve this remission? So here there is a wonderful trial called the, I'm sorry, yes, this is the Retune trial, again done by Roy Taylor. Here they have taken 20 patients with type 2 diabetes, but all of their BMI was between 21 to 27. They are all Caucasian patients. You know that the classification of obesity starts only above 30, but all of them are non-obese. BMI of 21 to 27 they included, and they gave hypocaloric diet and they reintroduced a normal diet, and again they followed these patients for a period of 1 year. And you can see BMI reduced substantially, the body weight reduced substantially in these patients. They were also able to achieve 10 to 15% of weight loss. Even though they are not obese subjects, they were able to achieve 10 to 15% of weight loss with hypocaloric diet. And you can see the body weight reduced, the waist circumference reduced. And what happened is that the liver fat was able to get reduced by 30 to 40% in these people. And again, you can see these are the markers of de novo lipogenesis that also got reduced in these people, and eventually without the help of any drugs, after stopping all these drugs, they were able to maintain good fasting blood glucose level and as well as HbA1c level, and you can see the triglyceride level also dropped down in these patients. So the remission rate at 1 year was 70% in these patients, which is equal to the remission rate which you are able to achieve in obese subjects. So now what we can understand is that there is some kind of heterogeneity, but not in the pathophysiology of diabetes, but there is some kind of heterogeneity in the capacity of storage of your triglyceride in the subcutaneous tissue. Some people can store more, some people can store less. So people who are going to store less triglyceride in the subcutaneous tissue, there will be spillover to the pancreas. They will develop beta cell dysfunction and diabetes very quickly. So with this, I am going to conclude. So we have looked into what is the cause of beta cell dysfunction. We just spoke about the twin cycle hypothesis. Chronic calorie excess will bring about will increase the hepatic fat content as well as the pancreatic fat content. Eventually it leads to type 2 diabetes. And again, with the help of low calorie diet, you are able to achieve substantial weight loss, and you are able to reduce the liver fat content as well as the pancreatic fat content. Is there any evidence? Yes, evidence is there in the form of counterpoint study. 8 weeks of hypercaloric diet, you are able to achieve remission in obese patients. Is it durable? Yes, I told you the counterbalance trial. And is it possible in clinical practice for us to achieve it? Yes, you have evidences from the direct trial. And again, is it possible in patients who are non-obese, who are having a normal BMI? Yes, it is possible. You have Retune trial. So with this, I conclude my talk. Thank you.
Thank you, Dr. Rajesh. Bringing out the difference between the remission and the reversal, and it's very nicely done. If there are any questions, we'll take.
I have a basic doubt. Diabetes is metabolic and vascular. So you have talked about, very well you have talked about metabolic remission. What happens to the vascular disease? Because diabetes is detected with vascular disease. So only it is not dealt by the topic by the foreigners, but we have been taught like that.
So these are all very small scale studies involving 20 patients, 30 patients, and done for a very small period of time. So here the what we are able to find out is that they are able to reverse their diabetes. Not only the diabetes, the pathophysiology which causes diabetes is also able to get reversed. Only thing what you are asking is that what will happen to the cardioprotection, what will happen to the vascular protection. We need long-term studies for that. We don't have long-term studies to prove that.
I have seen umpteen number of people fluctuations in HbA1c when they report the reversal. Can you please explain?
Sir, it's a broad, very broad question, because HbA1c, most of the labs it is not standardized. Number one, you have to go for a HPLC method by D10 by RAD. So that is one thing. Even if you are doing in a standardized method, no. It should be once in 3 months. If the patient is not affordable, it should be once in 6 months. But what happens is that there are so many reasons for variability in HbA1c. See, if you look into the glycemic variability, the most common reason for glycemic variability is poor adherence to lifestyle measures. They don't take their food properly, they don't take their medicine properly, they don't do physical activity. So obviously sometimes their HbA1c goes up, sometimes their HbA1c comes down. So this is very common we see here. So that's where we have to educate our patients, we have to motivate them to adapt to a healthy lifestyle so that they are able to consistently maintain their HbA1c in the target range. Yes, yes, absolutely. Sir, obviously when we talk about weight loss, it should be a healthy weight loss, not at the cost of your health. So here it is a healthy weight loss. By giving calorie restriction, you don't alter any pathophysiology in any other organs there. The only thing is that you are able to achieve a good amount of weight loss, some amount of reduction in the fat deposition in the vital organs is there. So without causing any other pathology, if you are going to achieve weight loss, that is going to be beneficial. In cancer patients, in patients who have tuberculosis, in patients who have hyperglycemia, there also there will be weight loss, but obviously it is because of it is a secondary weight loss due to some other disease, so that is not going to be beneficial for our patient.
Thank you so much for the session, sir.
For a healthy weight loss, we have to reduce the calorie according to what is the level of our physical activity. For most of our patients, for most of our people, it will be somewhere around less than 2000. So if you are going to maintain a negative balance, then we can bring about weight loss. If we take too much of calorie, obviously there will not be weight loss. So it depends upon the level of physical activity. It differs between a sedentary individual, it differs between a person who is too much physically active.
But actually in these studies, they have brought down the calories to 800 calories. That
Yes, 600 to 800 calories.
600 to 800 calories.
Very difficult, but again, these 600 to 800 calories was given only for a short period of time, for a period of 8 weeks. After that, with good weight maintenance strategy, with good physical activity and with reduced calorie intake to the tune of somewhere around 1500 to 2000, they were able to sustain this benefit for a period of 1 year. So, but how long, for longer, for 5 years or 10 years, whether that is possible, we have to answer it.
Any studies going on, sir, with lower limit of calorie, long-term effect?
Those studies are not available.
I think we have to remember this is just the beginning of
Correct.
studies that he has brought it to this forum. Obviously, we all of us know that it needs a long-term follow-up, and we have to wait for some more results to conclude those things. Those questions you are putting, you know the answer for yourself.
See, one thing is that when you lose weight, you also lose some amount of muscle. So that is important. Sarcopenia is inevitable. So how can you counter it? That you have to adequately take your protein intake, and then you have to do resistance exercise. 1/3 of muscle loss is also possible when you are going to lose too much of weight. Gallstone disease is also possible.
I'll just make one comment. The topic is diabetes well-being. One of the things that first comes to mind well-being is physical fitness. That is what it means. Physical fitness means you should be like 40 years when you are 60 years old. That is a physical fitness. You have to be strong, and your muscles should be strong, your energy should be, you should be able to climb 4-5 stairs. That is a physical fitness. If you lose muscle mass, that means you are not taking care of your diet. That's what it means. You are not taking care of the exercise that you are supposed to do. That is the point he was making. Any other questions? Any comments from Dr. Venkatraman?
Thank you so much for the wonderful session, sir. Now I request Dr. M. Swamikanan, sir, to present the memento to Dr. R.P. Rajesh, sir.
good beginning.
Thank you, sir.
We'll all learn as we go along. We'll
Thank you,
learn
sir.
about this reversal and
Thank you, sir. Thank you, sir.
Thank you, sir. Now I request Dr. A. Natarajan, sir, to present the memento to Dr. M. Swamikanan, sir. Thank you, sir. Now we move on to the next session, reverse panel in the topic of diabetes in young. We would love to have the moderator, panelist and presenter of this session on the stage. Moderator, Professor Dr. S. Venkatramanan, sir. He is a senior consultant diabetologist at Apollo Hospital, Chennai. And panelist of this session, Professor Dr. R. Madhavan, sir, and Professor Dr. K. Venkatraman, sir. Professor Dr. R. Madhavan, sir, he is a retired professor and director, Institution of Diabetologists, Madras Medical College. And Dr. Professor K. Venkatakrishnan, sir, he is a professor of medicine at Sri Ramachandra Hospital.
So good morning. Dr. Dhanmitran and Dr. Parandaman for this opportunity. I think started with a bang. Wonderful sessions. I think VG did talk about GLP receptor agonist, and Nalla Perumal was outstanding lecture. The way he talked about the first 1,000 days. I think couple of points, even though my topic is something different, I just thought for the sake of audience, I just thought I'll repeat it. So the fact that the epigenetic changes are heritable, I think that was one of the messages that he beautifully highlighted, and how God has designed the content of the breast milk. See, it is relatively low in protein, but that is a protective. So too much of protein, how it is detrimental. I think the couple of points, I think he shared a lot of good points, two things which I thought was very impressive, which I thought I'll, even though it was not my job, great lecture, nuts, a great thought. I think, of course, I was involved in part of the finalization of the programs. So happy to see the outcome has been so good. And of course, Rajesh, in fact, I've requested him to do this in so many platforms, and every time he does it in a way that it looks as if for the first time listening to him. I think you did make a mention about the distinction between the remission, reversal, and diabetes. So we had two excellent topics. Now we are going to shift gears. This is going to be a case-based discussion. So I always believe that in the context of diabetes, management of diabetes is always a challenge. Management is always a challenge. I think there is no one single prescription, there is no one single perception, but what we try to do with respect to arriving at a consensus or a synchrony with respect to thoughts, or appreciate the nuances of the disease, fix the target which is relevant for that particular individual, keep at the back of our mind the various guidelines, availability of the molecules, our own hands-on experience with the molecules, and of course the cost effectiveness. I think these are about 5 or 6 attributes we always take into consideration. So that always calls for an interesting discussion in the management. Whenever you talk about panel discussion, the management case-based discussion, it always evokes a lot of enthusiasm and interest. But when it comes to the diagnosis, quite often in diabetes, there is not much of a challenges in diagnosis, excepting in a very, very narrow spectrum, especially in younger age diabetes. Now, the diagnosis of type 2 diabetes mellitus, almost 100%, I don't think we'll have a doubt. So also type 1 diabetes, even though you may not have telltale evidence of having substantiated your diagnosis, but still clinically you are quite clear. But when it comes to younger age diabetes, wherein there is an overlap, you can have a type 1 diabetes, you can have MODY, you can have LADA, and you can have type 2 diabetes as well. I think here, the clinician with the available resources to him, or which the patient can afford, can have some meaningful investigations. Otherwise, you are justified in clinically making a diagnosis. So to do this job of a reverse panel, wherein focus on special changes in the management, so we're going to have our young dynamic Gauri. Dr. Gauri Shankar is from IIT, from the Army. I think Gauri and Rajesh and others have been part of our team who have enabled us to learn a lot. We have contributed a lot, and so also in this program. So there is going to be 3 cases to be discussed by Dr. Gauri Shankar, and of course, we are going to have valuable inputs from my 2 great friends, Dr. Madhu and I were in the department along with Professor Sundaram. Professor Sundaram was senior to us. We have worked under him as well. We were his colleagues as well as worked under him. Madhu and I were colleagues in the department for almost close to about 1.5 decades, and we have made a lot of learning together. We appreciated each other's knowledge. And recently, I have been in touch with Professor Venkatakrishnan. I've been thoroughly impressed with this, the way he approaches in a simple manner, abundant knowledge, the way he communicates. So it's going to be an academic feast for you. So the 3 cases, so we'll take about 40 minutes. Already we are behind schedule by about 20-25 minutes, 45 minutes. So that 10 minutes for the presentation and the discussion by the 10 to 12 minutes. Maybe 1 or 2 questions or comments for each case, if it is okay with Professor Madhavan and Professor Venkatakrishnan, so that there is going to be a case discussion with some amount of audience participation as well. So now I request Gauri Shankar to make the presentations, and request my friends Professor Madhavan and Professor Venkatakrishnan to be the panelists to discuss these three cases. Thank you.
Good morning all. Thank you, sir. Thanks for the entire team for giving the opportunity. Thank Venkatraman, sir. We are here with Madhavan sir and Venkatakrishnan sir. Sorry for my voice. So, we will be presenting 3 simple cases as said. Last time when we did the same panel, it was in young diabetes. It went for 1 hour. We will stick to the time this time. But at the same time, there was lots of controversies, confusions. So, we tried to do very simple cases this time. And we all evolved. So what I am going to do is, I will present the way I saw the patient, and we will take the learnings from the teachers based on what mistakes I did, how I should be clarified, so that you also can get the same clarity, the mistakes that we did in this case. So that is how the next 40 minutes is going to be. So we'll go to the case. The first case, he is Mr. Bidon. So he's a 34-year-old male. So when I saw him, he came with, he's a faculty who is working in our institution. He's from Rajasthan. On his routine checkup 2 years back, so he's a HbA1c, he was presenting with a 12.3. He was managed with insulin and other things. We don't know really the treatment history which was happening at that point of time. And currently his HbA1c is about 5.6. He's on linagliptin with metformin for 1 year, and he's fairly doing well. He's thin built, there are no features of insulin resistance, like lipids are normal, no acanthosis, normal individual, BMI is about 21. The other metabolic parameters are normal, his ultrasound is also normal, there is no hypothyroidism or any autoimmune disease. So a fairly simple case. So he is coming and sitting in front of you with a HbA1c of 5.7. Now I will ask both the teachers, sir, at this stage, do we need to really evaluate him, sir?
Good morning, and thanks D. Mantra for this opportunity, and thanks to Dr. Venkataraman for the nice words of introduction. As Dr. Venkataraman rightly mentioned, in majority of the cases, the so-called young onset diabetes, a good history will tell you what type of diabetes it is. Most of the time, you rarely have any difficulty in identifying the type of diabetes in a young person. But occasionally, there are some cases, yes, you have difficulty in making out the type of diabetes. I think in this case, it is remarkable that a person who is just 34 years with A1C of 12.3, initially managed with insulin, now he is doing very well with oral hypoglycemic agents for last 1 year. So that gives us a doubt with what type of diabetes it is. Definitely I will go into the history, including the family history, the lifestyle of this patient, and of course you did tell that there was no hypothyroidism or autoimmune disorders, but I would like to definitely work out at least with C-peptide.
Okay, sir. So his family history is fairly good, no relevant family history, sir? Nobody is there in the
first degree relative
no
with,
first degree relatives
with diabetes.
Yes,
and was he investigated with C-peptide?
At the time of diagnosis, they have not done. So two years back. So we need to do a C-peptide.
Definitely, I think I will definitely do a C-peptide. And in case the C-peptide is very low, I will even go for the antibody testing.
Okay, sir. So, sir, should the C-peptide be checked when the HbA1c was at 12.3, or should we do it when he is presenting to us at this stage? Means what I am going to ask is, he had a glucotoxicity at that point of time. So should the early doctor who saw them in Rajasthan, should he have done that C-peptide over there when he presented for the first time, sir?
The teaching is that if the patient at the time of presentation is highly symptomatic, for instance, he has polys, he is cachectic, with severe loss of weight, I think I'll wait for some time. Maybe treat him with insulin. That is the recommendation. If the patient, even if he is type 2 diabetes or any other type of diabetes, if it is going to be symptomatic with polys and weight loss, I will treat him with insulin. Wait for the blood sugar to settle down, then maybe do the C-peptide. But if the patient suppose presents in acute metabolic derangement, diabetic ketoacidosis, then I think there is no need. See, again, I always tell that C-peptide estimation is not always necessary in all the cases, young onset diabetes. Only in cases where there is a therapeutic or diagnostic dilemma, then I think you have to do a C-peptide.
Sir, in that case, should we take the lesson that C-peptide is not essential when there is an acute crisis, rather than it should be seen later when the sugars are getting settled, and it doesn't have any utility when there is an acute presentation of diabetes.
Exactly.
So that should be the lesson we should take.
Correct. Sure.
Okay, sir. Sir, you want to add some points?
So there are being GPs here. Yes.
Sir. Everything is normal, sir. I will show the next slide, sir.
Next slide, sir. So the benefit of general practitioners, so we may be having some high level discussion, but I will make it simple. So for your understanding, so any young patient, especially 25 years and less, now what is our understanding before was type 1 and type 2. Type 1 means young age, type 2. So that is almost, I am saying, 15 years back. So now everything is changed. It could be MODY or other type of diabetes in young age, not type 1 alone in young age. Yes, definitely. So that is what is the case scenario we are going to, this panel discussion is especially for you to understand. It's definitely a different scenario now. The second point is C-peptide necessary for all patients? I would say yes. When you diagnose diabetes, especially less than 40 years of age, you have a doubt. There are different types of diabetes. We will be learning from these case scenarios. I'll make it simple. As sir told, when there is acute crisis, definitely Gauri's and Madhavan sir's is well taken, but we would suggest, even if it is an acute crisis, these types of young diabetes, there is a rapid progression of C-peptide levels within months to years. That will tell whether it's type 1 or other types of diabetes. So it's ideal to do C-peptide even in acute crisis, at least after the initial crisis is resolved, better to do C-peptide. Otherwise, how do we know that after 1 year it has improved or worsened?
Sometimes the teaching says that when there is a glucotoxicity.
Yes, definitely agreed. I am saying initial glucotoxicity period, after he subsides, after 2 weeks, during follow-up, that time you can just assess C-peptide.
That is the most important carry-home point that we all need to take.
So that is very important. After 2 weeks, when he subsides, you have to do a C-peptide. After 1 year, if you do a C-peptide, there's a rapid decline in C-peptide. The diagnosis will go in favor of type 1 or other types of diabetes. That's what we are going to learn. From the next slide, he will put. So C-peptide measurement and what is the drug. So it is not that type 1 will require insulin, definitely we know. Other types of young diabetes, not that they should require insulin. They may respond to oral drugs, even they will respond to sulfonylureas. So that's what we are going to, that's the crux of discussion in this panel.
The fact that this patient is doing well with 2 oral hypoglycemic agents for a year, again makes it think whether it is type 1, because a typical type 1 diabetes will never be having this kind of picture with 2 oral hypoglycemic agents. So that is definitely a challenging task for us to decide whether he is really a young onset type 2 diabetes or a type 1 diabetes or any other like LADA. Again, LADA is nothing but a slow onset type 1 diabetes. Again, after some time they are going to require insulin, though they respond to oral agent initially.
Sir, in that case, do I need to do an antibody for this patient, sir? So 34, no insulin resistance, responding well. But still, why is he having this? So should I do at this point of time? Should I have in my back of my mind, okay, let me do an antibody and prove that he is not an evolving type 1 or so, or a LADA or so. So should I ask an antibody at this point, sir?
So we know that the literature says that with the onset of hyperglycemia, a large chunk of even type 1 diabetic patients may not have antibodies. And this patient has already been treated. Now he is on oral agent. And at this stage, when he is on 2 oral hypoglycemic agents, I will be a little reluctant to do antibodies.
Sir,
I don't know. Dr. Venki, you agree?
So,
yeah. I think at this stage, this is the first slide of the case. I think it has generated a lot of meaningful discussion. So thank you so much. Now, there are few aspects. I think what the questions that have been asked and then nicely answered by our esteemed panelists. See, a 34-year-old presents with HbA1c of 12.3. Now, these are all real-time cases. The cases handled by him, they are not fabricated. Now, what has happened is, presumably he has been treated with a good amount of insulin, complex doses of insulin, so that he is in what you can probably, Rajesh will agree, call it as a therapeutic remission with 2 agents, that is Lina and metformin. I'm sure. See, had this patient not responded that beautifully, his HbA1c has been 9, certainly we would have called for a C-peptide and a GAD antibodies. We are going to think about LADA straight away, because presented a very high, even though there is no ketosis, HbA1c has been 12.3. Why we present such cases is, these are the cases he has encountered. So for the discussion's sake, I would have even put this as 9.3, the HbA1c, follow-up HbA1c, so that the discussion becomes very, very clear. But that is a textbook description. But here, this patient, when Gauri saw this patient is on 2 drugs. At that point of time, I don't think, I would have said probably the patient presented with very high blood sugar level, complex therapies, HbA1c almost in the non-diabetic range with the 2 OHs, he is in remission. I wouldn't bother about doing an antibody at this time. But had the HbA1c not responded like this, certainly we would have gone in for a C-peptide measurement, at least after collection of glucotoxicity. Now, C-peptide, I think there are 2 aspects, I'm sure Dr. Venkatakrishnan and Madhavan will agree. In the case of a suspected type 1 diabetes, matter whether it in acute it's going to be almost 0, except in the honeymoon period, wherein you can have some recovery of the beta cells. Whereas in the case of type 2 diabetes mellitus, I feel it's worthwhile to wait for the glucotoxicity, because when you talk about the insulin secretion that is being handicapped, the hyperglycemia mediated insulin secretion is always the one that is responsible for the symptoms, be metabolic decompensation or symptoms. So once you correct it, then you allow that vulnerable beta cells to recover, so that it's a meaningful exercise with a more of a therapeutic implication to do a C-peptide after the patients recover. Now, coming back to the question, I think this patient with this scenario, had I seen him with a 5.7, I wouldn't do a GAD antibody, even though initially my suspicion would have been LADA.
So I was
the only place where we do a C-peptide, in my opinion, again, in a type 2 diabetic, is when the patient has failed to respond to oral agent. We want to introduce insulin, but the patient is very reluctant. Then maybe you can do a C-peptide and him see your C-peptide is very low, you are not going to respond to tablet. Though now with the advent of newer molecules, even that requirement has now come down with SGLT2 inhibitors and GLP-1 receptor agonists. I think even at this stage there is no need for a C-peptide.
Sir, so I was crazy enough. Sir, I will take the questions at the later.
Only one question.
Sir.
He has had diabetes, glucotoxicity, and he has settled with 5.7 according to reversal and remission. Why do you want to do any test at all?
Sir, correct, sir. So I was crazy. So I'm crazy. So I did a fasting, I did a postprandial, I did a HbA1c. I just wanted to see what is happening in the patient. So probably I'm crazy. So what actually happened is his C-peptide was normal, and I did a GAD antibody also. When he came, it was positive. So probably you may disagree, agree with this, we are not doing, but I had the facility, I did that. Now his GAD antibody is positive and his C-peptide is normal. So probably this is what has happened to this patient. So at this point of time, does the scenario change, sir?
To address Professor Samikannu's query, This patient, so, and the patient has responded from 12 to 5.7, so you can say the patient has responded, but why the need of antibody and C-peptide? Definitely, I would suggest you do, because in this scenario of from 12 to 5.7, what is the reason for his response to OHA? We have to understand. Whether what is the beta cell reserve, we should know. So, and antibody will have given idea how long these drugs are going to help him in the long run. And annual C-peptide is definitely indicated for this patient, whether there is a decline in C-peptide. That is, so just that the patient has responded in 1 year, HbA1c and come down. So we should be some in at least this type of patient. If it is 50-year-old, no problems. If it is 34-year-old young patient, it's always better. And now their antibodies are not very costly, so they are at most affordable for middle class people. Not others may not be able to do it.
No, if you add an episode of ketosis, or if you add LADA in mind, then maybe you are justified in doing an antibody at this stage. Otherwise, I feel he's doing extremely well without even insulin secretagogues. He is on only DPP-4 inhibitors and insulin sensitizer. So, what made you think of doing it?
Sir, I was just thinking, what is the reason he was presenting with such a high sugars, and why is he remitting so well? So he has almost achieved means we can stop the OHS also, but there is something underlying which is happening. So I just wanted to capture whether he is something LADA or so like that we should not miss. But he was ketones negative also, but still I thought like why not to do. So probably my mind said like let me do, and this is very recent, 23/10/2024. I saw him very recently. So I just thought let me do. That's what I said. My crazy mind was telling.
No, I think in retrospect you must be really congratulated. Now I tell you, imagine the scenario, this patient has been treated with some therapy by somebody. Supposing the HbA1c is 5.7, somebody has stopped the treatment. See, this Lina as well as metformin in my opinion is a red herring. Probably even without that is HbA1c. So probably he is in the, whatever you call it, remission or honeymoon phase or whatever it is, and the C-peptide is required. We do not have any idea about the previous C-peptide response. So this control with Lina with metformin, I wouldn't say just metformin and Lina are on board. He is probably in remission or honeymoon phase of type 1 diabetes. And having done that, I think you should be congratulated in my opinion. Because look at it. Yes, a small subset of type 2 diabetic patients can have GAD antibody positive. These patients, as Professor Venkatakrishnan said, probably their early response to, the failure is can occur early. Now the issue is, you have a young diabetic who has been on some therapy, who is on board with 2 OHAs, the HbA1c is almost in the remission range, and his GAD is positive, and C-peptide is normal. What do you do? I think this is where I think we need to carry forward the discussion. What I am trying to say is, when the response is good, even though the GAD antibody is positive, are we justified in continuing the OHAs? You know, it's going to be a question of time, maybe another 2 or 3 years, maybe, or even earlier, before he requires insulin therapy. Are we justified? So
I think if
because
you
why
say,
I ask this question is, somebody in our clinical practice, if you are confronted, encountered such a situation, you should not feel guilty. See, GAD antibody is positive. Have I done a mistake? No, you have not done a mistake.
once you talk about reversal, why you didn't think of type 2 diabetes in the young? What are the points which made you think that this is not type 2 in the young?
Sir, he's a very thin, no signs of absolute insulin resistance, metabolic profile is normal, no hypertriglyceridemia, nothing to say, suggest even a type 2, like why should 34 years with no obesity, nothing, healthy person, no family history, nothing was suggestive of type 2. Just I wanted to see, like we get lots of such young patients. So I'm just looking at back and lots of all these things are coming up. So probably just because I have infrastructure, let me do it. No, I can't be justified why I did, but it helped this patient. So, madam? Sir, his ultrasound is normal, FCPD is ruled. false positive GAD antibody, madam.
No such But in this patient,
No. I think more than calling the false positive, Madhu, more than calling it as a false positive, whether the positivity needs to be given a connotation in the context of switching him over to the insulin therapy. I think that is more important. Many other conditions wherein you can have some amount of autoimmunity, you can have some antibodies. But in the maybe even some of the non-diabetics can have GAD antibody positive.
GAD antibody positive.
So that only tells that some amount of autoimmune process is going on. But in the context of this discussion, whether we are dealing with a patient who is a LADA or who will require insulin, am I right?
I agree with you. Yeah.
Sir, the other two antibodies are not present, sir. I encouraged him to do an antibody in another lab, but he said he will take some time, do it in December. So I saw him in October only. So if you are going with your diagnosis with one antibody, always make sure that it is being checked in another lab also, so that we are certain that his antibody titer is really positive. So that is a very key message, as many of our seniors have said. So don't go with one lab or go with two antibody positive titers. Now his diagnosis is changed. It has become LADA. So now that it has become LADA, so what should we do for this patient, sir? Is there anything that changes our management, or should I, the SGLT2 inhibitors are there? Is there a place for those drugs? Or how should I monitor this patient? Should I go for an annual C-peptide or so? Like how my treatment henceforth should be changed, sir?
You said initial treatment with insulin for how many years?
Sir,
or months?
It was some 2-3 months, sir. OHS
Only
plus
2-3.
insulin, it was treated, but I couldn't get the records. He said he will get it in December. I'm yet to look at those records, sir.
So normally when you say LADA, there will be initial response for oral agents will be good. Then there is a gradual decline. Ultimately, within a few months or maybe a year or two, they become insulin dependent. So this patient so far is doing with oral agent, but you have come to the conclusion this is a case of LADA. So are we justified in continuing the oral agents now?
Sir, since he is doing well,
as Dr. Venki said, his A1C is only 5.3.
Sir.
So don't you think that you should withdraw the oral agents and see? And you said the C-peptide is even now normal.
Yes, sir. So since he is responding to OHS, should we really be switching over to insulin, sir?
No, you are not going to switch over to insulin with the 5.3 A1C.
So even OHS we can stop and see.
That is one thing you can do. Otherwise, you monitor very closely, follow up, do C-peptide frequently. Sir. Or if the glycemic level starts going up, then you know, I think his beta cell reserve is declining, and then maybe you can start him on insulin. But the moment you say LADA, are we justified in putting him on metformin and...
I think Venkatakrishnan and Madhavan, if you remember, we had in our journal club a recommendation from experts. It is not yet been captured in the guidelines. Even in the presence of autoimmunity, as evidence in this case with GAD antibody, if the beta cell reserve is good, the clinician is justified in continuing the OHA. I think that is probably the message that I wanted to share at this point of time. Number one, you need not feel guilty. Number two, you have a recommendation from a body of people who studied about disease on the young onset diabetes. We had an elaborate presentation by somebody. So the recommendations were by that authority, and not yet captured by the guideline, is if you have the evidence of autoimmunity, but if the C-peptide response is good, you are justified in continuing. So that doesn't mean just because the GAD antibody is positive, here the C-peptide is good and the HbA1c is really good. Maybe he will continue like this for 1 or 2 years. I think we will wait rather than...
With regular follow-up.
Yeah. Yet another option is, if you want to be very safe, if somebody is going to be, if you pesters, if he is very knowledgeable, if the patient is a doctor, since probably suspecting LADA, should I be on insulin? Best option will be to stop the Lena and metformin, wait for a few length of time, and then allow the decompensation or this thing to occur, the metabolic worsen. Then you treat them with insulin. These are the two options. But what I would have done in this case to continue with the Lena and metformin, but look right at the back of the prescription, GAD antibody positive, probably a case of LADA, may require insulin and follow-up. I think this has to be there in the prescription. What do you say?
Yeah, I agree. Totally agree.
So the key carry-home points are: don't put this patient on SGLT2 inhibitors. Make sure C-peptide you frequently see in these patients. So these are two other points that we need to know. This alpha-beta classification, you can use this, like it is very important to know where our patients fit in. When you are in doubt, just work on this classification. Now we will go to the second patient, Ms. Deepa, who is about 24 years. I saw her in 2020. When I saw her HbA1c, for all practical purposes, it is in the diabetic range. Her fasting blood sugar is about 108 and postprandial blood sugar is about 108 again. So, sir, what is the reason there is a discordance between this fasting postprandial sugars and the HbA1c, sir? Or, sir, basically, sir, okay, so, yes, sir, okay, just 1 minute, sir, I'm sorry. I'm sorry, sir.
Number one, now only she has started having the almost target blood sugar level. It might take some time for it to be reflected in the HbA1c.
So, Deepa is 25 years old. I don't know where I had lost the history. She is 25 years old. Again, she is a very thin female. She was admitted for her PhD studies. During her time of enrollment for the studies, she presented with an HbA1c of 6.9. That was the first time she was presenting. She again, her menstrual histories are normal. She didn't have any other relevant family history. Ultrasound is normal. No signs of insulin resistance. Her lipids are normal. Not suggestive of any future suggestive of type 2 diabetes and all. So I lost the first slide. So now she is presenting with this scenario. We will just see how she is progressing. It's a linear narrative. Sir, so these are the background points. Sir. Sir, she's not. This is done during her PhD, sir. She's routine.
Previously,
routine.
she was not.
Nothing.
You saw her for the first time.
2020.
And her fasting and post meal were these values.
Yes, sir.
And why did she consulted you at all? She had any? She was symptomatic, or she had family history of diabetes, or?
Nothing, sir. She just came to see me like my HbA1c is a higher. When she got enrolled itself, her HbA1c was higher. So she just consulted me like, should I do anything for this higher HbA1c? 25 years. She got enrolled for her PhD studies.
This is very intriguing to say that her fasting is around 100 and? Of course, we do not know what was her blood sugar previously. After all, the A1C is what it reflects the previous 3 months blood sugar.
Sir.
So at the time you saw her, A1C was high, but the fasting and postprandial were almost normal.
Almost normal. Sir. Yes, sir.
So I think it's a real diagnostic dilemma to say that whether to call her a diabetic at all, or you want to repeat the A1C in a different place.
Sir, her
she had any anemia?
No, sir. Her HbA1c was higher.
7.3 it was
in her
earlier.
place of study.
Okay.
So that time it was 6.9. So when she came, I did this blood sugar and sugar fasting PP and A1C. That is how she presented to me. Within 15 days of
she had any hemoglobin abnormalities?
Yes, sir. So we did her iron deficiency, anemia. Her hemoglobin is fairly good. We don't expect her ferritin is also normal. And we did a hemoglobinopathy study also. There was no evidence of any beta thalassemia or hemoglobinopathy. The question why sir asked is like when you have a hemoglobinopathy F or C, false F or H, it is falsely high. Just remember this mnemonic. F and H will cause HbA1c higher. S and C will cause it lower. So not that all hemoglobinopathies will cause higher. So we did that part also, sir. HbA1c has been ruled out. And she was not willing to take any medication, sir. So I couldn't, I don't know what drug to put her on at that point of time.
Why do you think of any medication when fasting is around, you said 100 plus and postprandial is 100 plus?
Absolutely,
Only the A1C is high.
Fine, sir.
So we don't treat A1C.
We don't
I don't know whether you agree, Dr. Venki. A1C barely gives us idea about the previous 3 months.
Perfect.
Of course, we have targets for A1C, but when this kind of scenario, I won't think of any medication at all.
Absolutely, sir. So I also thought the same way. She doesn't need any medication. We are just treating her a number by treating her HbA1c. So I said like, okay, come back after 6 months or 1 year. We will repeat it. She came after 2 years. So she took about 2 years to come back. This is in February 2022. She came with a HbA1c of about 7.3 now, sir. And when she came with a HbA1c of 7.3, it was presenting with a fasting of 143 and postprandial of 62, not on any drug. And she doesn't have any insulin resistance, not obese, nothing. So it looks like something like a fasting sugar is increased, hyperinsulinemic.
At this stage, I will do a C-peptide. Definitely, I will do a C-peptide.
Good, sir. Insulin resistant, so that's what we think. So she needs a C-peptide. So I was again like, am I missing something? Again, availability is there. Overdo it, do it. So insulin antibody negative, GAD antibody negative. I did a C-peptide fasting normal.
Gauri, before I think just a question or a loud thought, maybe that may not be the diagnosis in this case. Young lady, 24 years, asymptomatic, and then there's a progressive rise in the fasting blood sugar level. The HbA1c keeps rising. Why not Modi?
Could be, sir.
So from the clinical discussion, because of course you have got various categories of Modi. Glucokinase is the mildest form which you pick it up only during the during the period of gestation. Whereas there could be other forms of Modi which could be very, very disastrous from the point of view of the metabolic decompensation, like echinopon alpha. So at this point of time, even though you do not have the detailed family history, a young lady asymptomatic, progressively the sugar is going up, 24 years, maybe Modi. And one thing that I have found out in my practice is, I think Professor Sundaram nicely pointed out that the meals-related insulin secretion is good, so you have a postprandial higher, lesser than that of the fasting. One thing that I found out in my practice, I'm not too sure how many will agree, undetected hypothyroidism. If you have undetected hypothyroidism, when the fasting is higher and postprandial is lower, look for the TSH. Quite often I have found it to be, and once you correct it, then you have the anticipated response with respect to the concomitant level of the postprandial rising or coming to the anticipated levels, hypothyroidism.
So perfect, sir. So 3 things we need to think.
That is why I always feel that a good history taking is very, very important. I think the youngsters should learn. As the patient walks in to you for the first time, have a very good history. That itself will give most of the time. As Dr. Venkataraman said, if you are considering Modi, ask for the vertical transmission in 3 generation. If that is there, immediately you think of Modi and do a...
The parents are non-diabetic. That was taken in 2020 itself. So
though we say that genetic testing is now compulsory for diagnosing Modi, definitely initial history will definitely give you a clue.
Absolutely. Parents were there at the time, like they denied. We did a HbA1c for them also to know whether any latency is there, like that was ruled out. So family history is, no family history in the past 3 generations in the father circle as well as the maternal circles.
Ultrasound for
Ultrasound
PCOD?
Normal, sir. PCOD is ruled out, sir.
So we have only 2.5 minutes, but we'll be somewhat exceeding the time for one more case. So I'll make it simple for whoever is here. What we learnt is a C-peptide antibody and the progression of decline in C-peptide levels and genetic mutations. These are the 4 highlights we should know in treating any young diabetes. So now from LADA, initially there will be beta cell function, but some decrease in beta cell function will be there initially, but it progresses fast. Decline is fast and it becomes low. Levels will be low in LADA and there will be a specific antibody positive. That is LADA, the first case. The second case, as Professor Venkataraman has pointed out, why we thought of Modi is, we don't know whether it is clear Modi. Modi is a strong family history. That's what history is important. Now recent articles say that a few forms of genetic may not have a strong family. Family history in the sense, there should be 3 generations in the family who have developed diabetes at or below 25 years of age in the family. So a pedigree is needed to find out we have a pedigree here. So to say, that is very important. That's not a strong family history. And initially, C-peptide, if it is normal and the response to oral therapy is strong in favor of Modi. The last case we'll discuss.
So two things we need to think. One is like as Parandaman sir was telling, like there is a chance of being a hepatic insulin resistance over here. And the second thing, as Venkatraman sir and Venkatakrishnan sir were telling, like we should always suspect Modi in this patient. So I learned it the other way. Since there is a hepatic insulin resistance, I put the patient on metformin here. So the HbA1c jumped from 7.3 to 7.9 in 3 months. 2020, it was 6.9. And next time when she came, it was jumping to 7.3 to 7.9. So then I started like, okay, like let me put a small dose of sulfonylurea. And introduction of this small dose of sulfonylurea brought the HbA1c to 6.6. And after that, she was becoming reluctant in taking the medicine. Young girl, no. So you tell them to take some medicines, so they won't take. Compliance is very poor. So her HbA1c dropped to, again went to 7.2. This is her recent fasting blood sugar. It is in 2024. Same girl. So now the question of being Modi, like already it has been addressed. So type 1, could it be type 1? There are some features, but no antibody, no ketosis. Type 2, C-peptide is normal, no insulin resistance. So these are the other points which have been already discussed. She is not responding to metformin. Family history positive or negative. Sulfonylurea introduction helped in the control of blood sugar. There is a mild fasting hyperglycemia, which all shows that yes, she could be Modi. So Modi is something which we should not miss. Now I send her to Modi genes for a center. They screened for all 75 genes. And let us skip the family history and all. So this is the report we got from her. So none of the genes tested for any positive mutation. So Modi is ruled out. Yes, sir. Hypothyroidism has been done, sir. Yes, sir. 2-3 times we have. This is.
There is a raise in TSH, but you didn't do a...
No total count, sir, it is.
The previous slide. Look, next slide. See that TSH is...
Sir, that point we addressed, sir. After that 2023-24, she was on follow-up. Yes, sir. But we followed up there. We did an antibody also because we wanted to see, and when all the antibodies were addressed, the antibody was negative.
If you want to diagnose subclinical hypothyroidism, you have to do a free T3.
Free T3, free T4, free TSH has been done, sir. She's on annual follow-up. I'm just taking the snapshots because that point of time before starting, she's a young. She was planning to get married and all. So all those points have been addressed, sir. That 6 also was addressed. I have the entire follow-up with me. She is on regular follow-up. Sir, but 6...
So the guidelines to treat subclinical hypothyroidism. So the subclinical hypothyroidism is 5.5 to 10. And if you have a specific clues, not all subclinical hypothyroid should be treated. If it is pregnant patient, a patient's puberty, just attained puberty in the menstrual cycle, there is disturbed menstrual cycle, with other features when the patient has a subtle features of hypothyroidism, or a patient is having diabetes related issues, they have to be treated, but free T4 value was normal as he says. 5.56 and all, usually we always wait in other patients. Diabetes, pregnancy, abnormal menstruation, all other patients, you can wait and repeat TSH after 6 weeks. That's what is I think.
What about the C-peptide at this stage?
When, sir?
When you started a hypertension?
Sir, that time also it was normal, sir. Even C-peptide, it was normal, sir, both fasting and simulated, because the antibodies we did last year only, sir. Even that time, her C-peptide, all 4 antibodies were checked in that center. where her genetic study she underwent. So over there also her TSH was normal, C-peptide was normal, and all 4 antibodies were negative. They do it routinely, but it was done in that center also. Means they do it for.
I think in clinical medicine,
Sulfonylurea shows that we know that Modi is a secretory defect. So probably this is a case of Modi. I don't know unless you tell me what is the current scenario.
I think you'll agree that in clinical medicine we are always given the advantage of having a query. So can we say this patient query lean type 2 diabetes mellitus? What you have to give a label, and you can always, you don't have to it's not type 1 diabetes, it's not type Modi, it is not LADA. So by exclusion.
To make it simple, you call it an atypical diabetes. So we can, that is definitely.
Atypical diabetes is different.
In that, you can say lean type 2 diabetes.
That's what.
One of the, because why it is, they are all confused that why first time they told Modi, now they know. That Modi needs some genetic mutation and a family history. In this patient, it's negative. That is why it is not Modi. Definitely the patient is responding to sulfonylureas. That is a strong indicator. That is why initially we thought it is Modi. But when it is genetic mutation is not confirmed, it is better. So we stick to a lean type 2 diabetes or other forms of diabetes.
Diabetes is always a problem. See, the patient is under good control. All of us are debating what it could be. Why not accept that? No, I'm just saying it in a lighter vein. I think that is the charm of academic discussion. I think the organizers have been kind enough to give us more 5 minutes extra. We are exhausting that also. So we'll go on to that. So to sum up, the first case was probably a case of LADA, but not probably a case of LADA, presently responding to OHA. The second is probably a case of a lean type 2 diabetes mellitus. Modi has not been proved, even though the possibility was very high. We will go to the third case.
Sir, quickly we will see, like maximum 3 minutes it should take. He is Mr. Arul, recently joined a BTech degree. So 18-year-old male, he's from some near Trivandrum, Kollam. In his routine checkup in his home where he had seen before admission, he had seen over there. His HbA1c is about 16%, blood sugar random more than 500, no ketosis, thin build, no futures of insulin resistance, no family history, BMI is 20, ultrasound normal. Other metabolic parameters are normal. The discharge summary shows thyroiditis. Otherwise, no other autoimmune disorder. But when I saw his FT3, FT4, TSH are normal. When I saw, but the discharge summary shows thyroiditis. So, during the time of admission, what they have done is, he was admitted for this sugar with HbA1c of 16%, and he was put on insulin. I'm just presenting what the doctors did. My contribution is very small in this. So his insulin antibody, they did very nicely. Insulin antibody is negative, insulin islet cell antibody is negative, GAD antibody is negative because he is presenting like a type 1, no ketosis. All antibodies are negative, and zinc transporter antibody is negative. His C-peptide is normal. So now on discharge, blood sugar 500, no ketones, but antibodies are negative. So he was put on insulin human mixture 10-4, Dapify-S, SGLT with DPP-4, GMER DS, 2DS, 101. They have done so much of evaluation and so much nicely they have treated. But why all these drugs? Is he really type 2? I'm really, I just want to take your opinion, sir. How do you comment this?
If you have asked me before giving this data, I will definitely treat it as a type 1 diabetes. Maybe a slow onset type 1 diabetes. Sir. And we also know, I think Dr. Sundaram is there, Professor Venkatraman is there. Those days we always used to say, Indian type 1 diabetic patients do not have this explosive onset. Even at the time of developing type 1 diabetes, they still have some beta cell reserve. So a little amount of beta cell is insulin secretion is enough to prevent fat breakdown and ketosis, prevent ketosis. So we always believe that Indian type 1 diabetics may not have ketosis even when the blood sugars are very high at the time of diagnosis. So if you have asked me that question before this slide, I will consider it as type 1 diabetes straight away.
Sir, but even then, are we justified in giving so much of OHS?
No, absolutely not. Even if you say that he is not a type 1 diabetes, at this stage I will be little reluctant to give dapagliflozin. especially dapagliflozin.
Sitagliptin, sulfonylurea, so much and all, sir.
Yes, definitely I will not give.
It should be pure insulin. This will be actually dapagliflozin should never be used. Definitely should never be used. And metformin, when you can see 1000 BD, 2 grams they are given.
So I think in any situation you always have a working diagnosis. I'm sure all of you will agree. Professor is there. So the working diagnosis in this case is type 1 diabetes. It is type 1 diabetes. Yeah, there is no, ultrasound is negative. So we used to call a type of diabetes as PDPD, protein deficient, but his BMI is 20. Somehow that malnutrition related diabetes from the point of etiology has not enjoyed the reputation of the people across the globe, even though we always try to, and I think Mohan Center, Vijay did a lot of work on that because, and also people from Orissa, we used to be our good friend. So there are some pockets of work from India, I'm sure Madhu knows about that. These are the places wherein we believe that the pancreatic diabetes, if you have calcification, calcific FCPD, or it's a PDPD, that is still the problem was related. This was a concept which was there in the 80s and 90s, unfortunately not gaining much of popularity. So when you call it as pancreatic diabetes, it's a secondary diabetes. So for which you should have telltale evidence of structural or functional disturbance in the pancreas, exocrine as well. So that's my understanding. So here the working diagnosis should be type 1 diabetes mellitus, and patient has to be on complex doses of insulin and then need to be followed up because, and the working diagnosis, my opinion, if you agree, could be type 1 diabetes.
So that is the most important carry home message that we need to know. In spite of, even if they are, sir, you want to say?
We'll have some questions, interaction,
sir,
so that we can wind up.
Last year, for some time before it started, my professor used to say, okay, 3 drugs fine, insulin will be started. Some people say that blood sugar level exceeds 300, we don't start insulin. Which way you have to take the presentation? This patient was here more than on more occasion.
Sir, I didn't.
Sir, no, probably what you are asking is in the context of type 2 diabetic subjects, as a rough guide, when the response to the third OHA is not likely to be captured, I mean, addition of a third or a fourth OHA, you have to be on insulin. That is the context of type 2 diabetes mellitus. Here the patient is young, presented with a very high blood sugar level, BMI is 20, there is no telltale evidence either of type 2 diabetes or type 1 diabetes, but a working diagnosis will be type 1 diabetes in this case. And only on insulin. I think it's a blunder to introduce all the OHs. I think if I can use it in a very mild form, it's a blunder.
So the guidelines are very clear. To start an insulin, RSSDA specifically says HbA1c more than 9, RBS at any point is more than 300. The first choice should be insulin, irrespective of the type of diabetes. It's very clear. At the time of diagnosis, that's what was your question. They should have started insulin.
So the previous slide, I think this is a very good slide. I think we kept on repeating it, the previous one. Yeah, beautiful. So whenever you have a working diagnosis or even worked out diagnosis, I think this classification based on autoimmunity and beta cell secretion, if you have this concept, I think it becomes very easy. Either it's a type 1 or a type 2 or a MODY or a LADA, whatever it is, I think you have evidences, and it's not very expensive to document this, excepting probably the genetic studies, which probably you can take the help of some of the centers who are doing focused work on this, wherein you can have the genetic studies in suspected cases. So with
the
this,
most important carry-home message I will say is that for the youngsters especially, at the time you see the patient for the first time, it is not necessary to give a label.
Sir.
You treat
Yes, sir.
the hyperglycemia depending on the level of hyperglycemia, and then you can always give a label later. You don't give a rush, and that is the lesson we learned from these 3 cases.
Third case, that is the most important thing. Don't try to rush even based on this classification. Based on this classification, you will fit into type 2. But as Sir said, it is a blunder to introduce so much of OHS. Please be gentle on the patient in giving insulin. Later we can know. So now he is doing well, stopped all OHS. He needed small dose of insulin. We have done a genetic study. Probably he may be a MODY, but immaterial. He should be on insulin, not all these OHS, especially not dapagliflozin and all. So even this classification, don't follow it by chart. Use always our common sense. So that should be the most important carry home message.
Before we conclude, I think if you want to have access to a lot of young people, join IIT, because he has a 24-year-old girl, 30-year-old lady, and of course, the first one was a male and second year. Anyway, that was in a lighter vein. So to sum it up, we had a first case, a 34-year-old male, a colleague of his in a faculty, presenting with a high blood sugar level, treated with complex therapies, presently on control with 2 OHAs on board, autoimmunity positive, GAD antibody positive, C-peptide as on date is good enough. Are we justified in continuing the OHA? The answer is yes. What is the diagnosis? Probably LADA. The second case, yes, a young girl presented with rising levels of blood sugar level, warranting treatment, poor response to metformin, brisk response to sulfonylureas. Whether it is MODY, maybe, but we are not able to document it because of the absence of information for the 3 particular generations. And then the genetic workup, I think, which he has done, commendable. All the 75 genes which are probably the identified loci, they have been identified, it's going to be negative. So probably it's a lean type 2 diabetes mellitus, even though the possibility of, and let us accept the response to OHA has been good. Follow up. The third patient is, everything is negative, 18-year-old boy, presenting with a high blood sugar level, ketones negative, all the antibodies negative, but still, I think the working diagnosis could be type 1. And then the tendency, or shall we say the inclination to introduce a OHA should be thoroughly discouraged in these patients. Insulin should be only the treatment of choice. Thank you, Gauri, for, I think all these 3, give him a big hand, because these are all 3 cases of his original. So whatever was done by others, whatever he has done, he has shared it very, very, in fact, last night we had a discussion. He said, I'm going to share whatever I have done. So there is no question of editing or anything. It's absolute transparency. I really appreciate you for sharing with us whatever you thought at that point of time, and had the inputs of our experts in the field of diabetes with decades of experience, Professor Madhavan and Venkatakrishnan. Thank you so much for your meaningful inputs. I hope you all enjoyed. Discussions like this can go on and on, but we have to give, accommodate other meaningful programs which have been so nicely formulated by the scientific committee. So thank you so much.
Thank you, sir. Now I request Dr. D. Dhanamitran sir to present the memento to Dr. Venkatramanan sir. Natarajan sir to present the memento to Dr. R. Madhavan sir and Dr. K. Venkatakrishnan sir. Thank you, sir. Now I request Dr. P. Parandaman sir to give the memento to the Dr. Gauri Shankar sir. We move on to the next session. We would love to have the chairperson for this session on stage, Professor Dr. A. Sundaram sir and Professor Dr. P. Parandaman sir. Professor Dr. A. Sundaram sir is a retired professor and HOD at Dr. Ambedkar Institute of Diabetes. And Professor Dr. P. Parandaman sir is a retired professor and the head of the Department of Medicine, Government Keel Park Medical College. And the speaker of this session is Dr. V. Mahadevan sir. Dr. V. Mahadevan sir is a senior consultant diabetologist and interventional cardiologist at Kaveri Hospital and Vadapalani.
Good morning to all. Diabetes and healthy living. Under this we have two important topics: diabetes and prevention of complications. Prevention. Correct. And prevention, early detection and management of different stages of CKD. First, I would request Dr. Mahadevan. Already introduction slide.
No problem, sir.
Senior interventional cardiologist. I think we'll have to remember him as a diabetologist because he did the diploma in diabetes. So, cardiometabolic, no? Cardiometabolic physician. He will be talking to us on aggressive management of risk factors, early detection of CVD and prevention of complications. The topic is very big and you have to, I think, Nalla Perumal's lecture we have listened. I think you would also listen.
Yes, sir. Thank you.
The stage is yours.
Thank you. So I would like to thank the scientific as well as organizing committee of the D Club for giving me the good opportunity to interact in front of my seniors as well as my friends. So my topic of the day is how you are going to how you are going to identify the risk factors for the cardiovascular events, and you are going to screen and you are to address in order to prevent the complications. So one of the best slides I present in all the meeting is one of the first duty vision to educate the end master to not take the medicines. Otherwise, prevention is a better tool to address the progression of the disease. So we have to encourage the individuals, instead of going for a MI, instead of going for heart failure, what are the methods you can adopt to reduce its impact on the negative impacts. One of the problems we commonly encounter here, many of the heart attack or many of the heart failure, the prime etiology that gives way is diabetes mellitus. And this is a nutshell topic. And diabetes and complication is very, very wide. So it affects both micro, macrovascular complications, all the tissues of the bodies. You can see nearly 35% of the people having diabetes have any event of cardiovascular disease. And nearly 64% of people, even without heart disease, harbor some risk factors like high obesity, smoking and so on. The worst factor is nearly 22% only is taking the medications. So patient with heart failure, heart disease with diabetes, nearly 22% only people are taking the recommended scientifically proven medications in nutshell. And other around, delayed intensification also plays a major role for more complications. So if you delay the treatment of HbA1c, if you don't give the HbA1c of less than 7, over a period of 1 year, you are going to increase the MI by 67%, stroke by 51% and heart failure by 64%. Otherwise, out of 2 individuals, if you are not able to opt the glycemic control less than 7, if you delay the intensification by 1 year, the problem of both all the vascular events is phenomenally increased more than 2/3 of the individuals. And you not only treating here, so when the patient comes to MI or microvascular complications, not. The problem starts earlier. Problem starts even at the time of the diagnosis of the diabetes, because all the things shares a common solve hypothesis. The people with diabetes harbor high risk of hypertension, high risk of dyslipidemia, everything joins together, and the problem starts as early before the diagnosis. Before the MI, the patient comes to your clinic and addresses for any primary or lysis, the problem would have started at the time of onset of diabetes itself. So if you keen on treating at this point of juncture, the problem of getting any complications can be prevented. So give more importance, weightage for the diabetes control, hypertension, obesity, any other CV risk factors for that matter. So prevention is far better. So screen the individual, all the diabetic individuals comes to your clinic, screen for hypertension, screen for dyslipidemia, screen for any onset of any vascular events, maybe a stroke or maybe a heart failure and so on. And earlier diagnosis can save the organ from its end damage. So treating at part can save the damage of the myocardium, can save the damage of the brain neurons if you properly initiate the treatment. So earlier assessment, risk assessment, magnifications also has a private role, and early diagnosis also gives much more weightage than waiting for a longer duration. So the CV risk in diabetes is continuing. So the CV risk starts even at the time of diagnosis, not at the after 10 years. So no need pointing of screening for MI or heart failure after 10 years. If you give much more weightage on the day 1 of the diagnosis of diabetes or hypertension, hypertension, you can avoid the escalations of these failure in nutshells. So give much more weightage for the prevention angle than going for the treatment of the complications. That has to be given weightage. And all the trial has clearly shown, the ACCORD trial or ARVAN trial, you could be earlier intensive glycemic control throws much more benefit in terms of microvascular events. And long run, over the period of long years, the follow-up study of the DCCT and UKPDS has clearly narrated that's a yearly control. When it's carried over a longer period of time, you can even reduce the macrovascular events. So other way around, if you leave the earlier period in a less stringent control, if you adopt the patients to have a free lifestyles, if the sugar levels is not under control over the first 5 years or 10 years, if you want to control later part of the times, you are going to produce more harm for the individuals. That was clearly alluded by the ACCORD trial. So from these trials, from these data, we clearly shows that yearly intensification therapy plays a pivotal role if you want to avoid complications of diabetes mellitus. So what you want to do, how are you going to assess any diabetic individuals comes to your clinic? There are many CV risk factors which are modifiable, which are non-modifiable. So we can target what are the modifiable risk factors. So pay attention for health diabetes, avoid the habitual smokings and alcohol consumptions, give more weightage for screening for hypertension, dyslipidemia, other parameters that can have a negative impact on the heart. Also give much more weightage for the social risk factors like anxiety, sleep disorder. So not only give more importance to the HbA1c control, keep an eye on their activity, on the psychological factors in terms of that. Even air pollution, which is commonly now roaming in capital of India, can also have a negative impact in terms of cardiovascular events. So diabetes and TV risk, initially diabetes is long content. Once a patient gets diabetes, is considered as a cardiovascular risk equivalent. So diabetes also increases the coronary death events. So patient with heart failure also at risk of developing diabetes. Diabetes also may give more payment for even limits. And diabetic individuals once go for MI, any revascularization has been in, whether CABG or stenting, even the post-follow-up period is more vital. The restenosis rate very, very high in diabetic. Even if we put a stent, the disease process is not going to stop here. It is going to be aggravated. So once stent is given after 5 years or 10 years, the restenosis rate is also very, very high in this population. We don't have control. So cardiovascular risk events in diabetes and with or without the presence of metabolic syndrome, that is central obesity and visceral adiposity, everything gives much more weightage. The presence of hypertriglyceridemia, low HDL, everything doubles the event of CV events. Even though metabolic events, metabolic syndrome, they won't take LDL. They won't take LDL as a parameter. Even the presence of triglycerides, even the presence of HDL, hypertension, everything joins together to aggravate the accelerated atherosclerosis happening earlier. How your risk categories? Any patients comes to my clinic, how these patients high risk or very high risk or moderate risk, how you want to category. So any diabetic with the CV events or any vascular events, you categorize as very high risk. Any end organ damage, patient with CKD, any patients, any microvascular events, and the duration of diabetes crosses more than 20 years. Even type 1 patients are categorized as very high risk categories, and the duration of diabetes plays a major role. That is the reason many of the trials says intensive glycemic control starts from the day 1 of the diagnosis, and high risk people diabetes without any organ damage, but duration alone is taken into consideration, plus any risk factor, patient having diabetes, hypertension, diabetes with smoking will be taken as high risk. Young people with even type 2 1DM or type 2 DM or younger age less than 35 or 50 years and duration of diabetes with 10 years, even they are considered as moderate. Why you want to give moderate risk? Because the vascular problems, the vascular disease happens, even the diagnosis of diabetes happens. So that is the reason they give much more intensity statin therapy for even diabetic individuals. If I analyze the target LDL for diabetics is far lower than that of a non-diabetic individual. That is the reason we give moderate risk even the diabetes is there. How you are going to assess the risk? So you want to, if you want to subject all the individuals for coronary angiogram, or if you want to subject all the patients for any intervention, no, it's not so. So how you are going to segregate the individual, whether this patient is because high risk, you say these are the risk factors, you are going to classify the patient is very high risk and moderate risk. How you are going to segregate the patients? There are so much of scores available, even apps, mobile apps have been documented helping in our desk to assess which patients falls in which category. Many CV risk factor, but we don't have any designed CV risk factor for India. Or even Asian continent, we don't have. We follow what happens in the western part of the globe. One of the largest score which was addressed by all the studies, Framingham's risk score calculator, which you can available in the app itself. This is a Framingham risk score, but we commonly it has not been practiced.
Next in US is this ASCV risk factor. Any of the diabetes care journals, it is how you are going to intensively statin based upon this calculator, AHA or ACC calculator. They assess, they put many parameters. What is the patient is having diabetes, patient is having hypertension, patient is dyslipidemia. In the dyslipidemia, they target what is the total cholesterol, what is the HDL, and smoking habit. So many parameters. If you incorporate, they will give us score parameters. What is the risk factor? In the risk factor crosses more than 7.5%, then in the 10 years, when the ACV risk score crosses more than 7.5%, these people are at risk of developing any ACVs. These patients require intensive statin therapy. So design the statin therapy to optimize all the parameters. This calculator was used. It is easily available in. Another is UKPDS risk engine was there. This is also known as the tool to assess where you want to stand, how you are going to optimize the therapy for the individuals. Another score, Europe they follow, so score 2 and the score 2 old patient score. It is everything is available in that. You have to feed the parameters the software applications here. Then they will give a risk estimation. But many of the trials was confined to their geographical locations. So none of the Indian patients have been incorporated. Thus are the limitations. So many of the scores we have is from the western part of the globe, which cannot be extrapolated for the Indian continents. And many of the things they place whether the patient is having diabetes or not. They won't take whether diabetes is controlled or not. What is the fasting level? What is the post-meal level? What is the HbA1c level? They won't put. They say whether you have a diabetes or not, whether you have a hypertension or not. They won't say what is the level of hypertension, whether the stage 1 or stage 2. Nothing that was not incorporated. These are the limitations. So inconsistency. If you put one score ACVD for individual, if you put Q risk score for individual, you have a disparity in terms of CV risk calculations. One to say you need high intensity statin, other parameter says you can read moderate intensity. So much of diversity in designing the risk factors tool is there. And these are the limitations. They won't incorporate much of the things. So risk assessment based on biomarkers. So if you adopt any risk factor as per your Indian subcontinent, you can go for J risk factor or Q risk 3 factor, which can have some sort of resemblance to the Indian population. If you want to go for risk factor adaptations, I recommend Q risk score in your day-to-day practice. Next in line, many of the times patients comes with a muscle checkup. They give high elevated CRP. So patients are at risk of developing CV events. High sensitive CRP alone, we cannot have a risk factor stratification. Based upon high CRP level, no need to treat the individuals. But urine albumin excretion is a marker for endothelial dysfunctions. It is not confined to the kidney alone. Elevated albumin excretion creatinine ratio is a marker for endothelial dysfunctions. The people with microalbuminuria are at risk of even macrovascular events. So don't give much weightage alone for the kidney. So elevated microalbuminuria is going to produce only the problem with the love kidney is not so. So elevated urine albumin creatinine ratio is a marker for even cardiovascular disease. In a nutshell, you have to take into considerations. And other tests, what you want to test, what you want to TMT for all the individuals. Asymptomatic individuals as routinely wanted to prescribe the exercise, how much amount of exercise can do, how long the intensity of exercise, you can do TMT. But to rule out CAD, any occult CAD is there, any patients asymptomatic, diabetic patients of 5 years duration having hypertension, if you want to rule out CAD, occult CAD individuals, TMT alone is not going to do any benefit for the individuals. But when you want to prescribe the level of intensity of exercise, how much amount of intensity you can do, how long you can do, you can for that you can have a tool as a prescription tool. You can do stress tests in your day-to-day practice. So routine screening for exercise is not recommended. Next in imaging, we do many of the times you do carotid edema media thickness. When many of the styles fail to say what is happening at the level of coronary and carotid is entirely different. So carotid edema thickness may have a marker for endothelial dysfunction and atherosclerosis, but these people may not be a probable candidate for a CV disease. And next in line is coronary angiography, CCT, coronary angiography on all the diabetic patients you want to subject for CCT impediments is not so. It is not given any prognostic benefit. So yearly once allowing a patients for going of CTC, you are told that diabetic individuals are at risk of CV events. Diabetic individuals are at risk of nearly 60% of the people are at risk. If you don't have diabetes control, you have more problem in terms of coronary events. But are we justified to send these patients for regular CT, CAG is not sure. But one of the things, asymptomatic individuals, if the score is very high, any patients comes to a clinic with a diabetic individuals, asymptomatic, not having that, if you put the score, whatever you score adopt, ACVD or Euroscore, score OP, anything you adopt, if the risk factor falls in high category, you have ability, any family, strong family history there, you can go for assessment of coronary calcium score. So coronary calcium score and CT coronary angiogram is entirely different. Coronary calcium score is a low intensity CT radiation is there. So minimal, like a X-ray, they will be subject to assess the coronary calcium. They won't use any dye. The radiation exposure is very, very minimal. So no problem of giving a dye then producing a kidney damage is not so. So real calcium shares can be added. So what is it and how you, where do you get? So calcium score is a prognostic marker for atherosclerosis. Initially calcium deposits anyway we thought it's a aging, but it is a marker for inflammatory changes happening across the coronary tree. So any changes, any atherosclerotic changes happening, the problem of revascular, the problem of atherosclerotic progression, the pathological calcification occurs along the coronary tree. So any calcium deposit in the coronary arteries is a surrogate marker there is a atherosclerotic plaque formations. That we have to take into considerations. Depending upon the aging and so much of things we have to take into considerations. And this is very easy, the CT coronary angiogram. For calcium assessment, I am not talking about coronary angiography. So I am not talking about injecting a dye procedure. I am talking only just we are like doing a CT scan. So it is using a 3 mm slice CT of an exact coronary artery, and the radiation dose is very, very minimal. You can see the radiation dose is only 1 millisievert. It's very, very low, as like taking a digital X-ray. And the scan is performed, there is no need for contraction, there is no need for taking heart rate control. So if you want to give a CT coronary angiogram, we need heart rate control is to be there. We need dye injection. For that we need creatinine. What is the creatinine level? So pre-medication has to be given, which is not needed to doing a CT calcium assessment coronary angiogram score. So unlike CT coronary, it is symptomatic even, but when the patient is having symptoms, patient having exertional breathlessness, chest discomfort, angina, calcium score should not be done. We have to go for either subject CT coronary angiogram or a conventional coronary angiogram. Please understand, this is all done for asymptomatic individual with high CVD score. So not for all the patients. Not all the patients comes to your clinic, type 2 DM patients, subject to calcium assessment by CT. Patient is asymptomatic and score should be in the high risk score. Then only you can ask the patient to go for CT. And they give the value based upon this. Whenever the Agatston score crosses more than 40, the probability of event is more than 20% next 10 years. So when the calcium score crosses more than 400, but up to 100, don't worry about that patients, because you can even no need for statin. When it crosses more than 100, the patient harbors any CV risk along with. Patient is smoker, patient is in a centrally obese patient having other risk factors, family history of CAD, even young age, you give moderate risk or moderate high risk. So 100, you have to give to more than 100 you have to check, but more than 400 put the patient on high intensity statin, because risk of events is very high. This is the score. They won't use any dye. You can see the LAD. I think lighter is not working. LAD, you can see this is LAD. That is the calcification. It was there on the LAD. You can see 0 calcium. There is no calcium at all. They will 1 to 100 is mainly Hounsfield unit. They calculate with the software. They measure the density of the calcium across, the length of the calcium across the arteries. They count with the Hounsfield units. Based on that, they arrive at score. So when you can see the more than 300, see many number of calcium is present from the left main itself to the LAD, L6. So density of calcium speaks about the quality or amount of atherosclerotic changes happening across the trees. So this is calcium scores. The independent prediction of cardiovascular events is the benefit of this calcium scoring is, and you can assess with the traditional risk factor scores. The people having high risk factors, you can ask these benefits. Calcium, who are the patients should undergo scanning. So calcium scoring apart from asymptomatic patient with intermediate Framingham risk. These are the people are good tool to assess calcium scores. But don't do for a history of any patient having symptomatic patient, don't do. Either you can go for coronary angiogram, because under unwanted radiation, unwanted procedure is going to give. Calcium score in appropriately for low risk patients. If they have any high risk futures, so any score is, in a 10-year score is very low, you want to subject the individuals, not needed. All the low risk patients cannot be subjected to calcium assessment for the coronary arteries, but they harbor other futures. Have obesity, have some sort of futures, family history of premature heart disease, yes, you are at liberty to do this. Calcium score has been convincingly predict the future events near total, even asymptomatic population, can also have a tool to assess what we can do for the individual at earliest before going for MI or events. So calcium, why should not, who should not do? Because patient have symptoms, very high symptoms. The other way around, intermediate risk factor you subject. Low risk, no need for the calcium assessment skin, and high risk, you have to go for other process, conventional coronary angiogram or CT coronary angiogram than for this. So in nutshell, patient have 45-50 years, asymptomatic individuals, if the risk score is intermediate, 10 to 20, they are the suitable candidate for a calcium assessment, not for all the individuals. High risk individuals, please don't do calcium score assessment, otherwise you can go for a coronary angiogram itself. And people have low risk, if they harbor high other mortality events, like CV risk events, they are subjected. So intermediate risk is advisable to do assessment of calcium. So can we repeat? Suppose this test today my patient was done. This was and then next, how can I repeat the patients? Whether you want, yes, you can repeat it because of we don't use much amounts of contrast, we don't use more amount of radiation. Even the calcium score is crossing more than 100. So you are you can do it after 3 years or 6 years. The patient remains asymptomatic. So after 3 years, you can do repeat CT coronary angiograms for the individuals. So based upon, I'll take another 1 minute. Based upon this risk factor, so focus on the intermediate risk factor alone. When the risk factor crosses more than 7.5, the statin is recommended, even irrespective of the lipid profile level. Even the lipid profile is very low. If the CT coronary angiogram score crosses more than 7.5, they require high intensity statins. So if you want to prevent the future events. More than 20, definitely you are going to subject the patients for invasive procedure like coronary angiogram. So we are going to start the patient high intensity statin. So where we fall means patient having 7.5, when the risk factor crosses more than 7.5, if you do the CT coronary angiogram, if there is evidence of calcium, please put the patient on high intensity statin because there is a vulnerable block, irrespective of the baseline lipid profiles. And next, patients having this also, patient having coronary scores, hypertension also becomes a problem. So patients having hypertension management is also very, very high. So with the patient having high calcium score, 130 of BP has to be addressed because the progression of atherosclerosis, the plaque rupture is very common in high hypertension people. So stage 1 hypertension patient, if the calcium scores is very high, the patient when the BP crosses more than 130 or 140, the patient have calcium score, you have to treat the patient with hypertension. So other management of CV risk factors, we have to curtail the other causes like hypertension. Everything has to be taken into consideration whenever you design the therapy for the individuals. Many of the CV risk factors happening, most cause of death in a diabetic individual mainly from the CV spectrum. So we have to tackle not only diabetes, we have to give much more weightage for the hypertension. Predominantly we use ACE inhibitor, ARB. If on top of that, you can use beta blocker if there is a need for ACE events prevention. So beta blocker is not contraindicated in all the patients with heart disease. You can use appropriately beta blocker when there is a need. And a cardiac selective beta like bisoprolol or metoprolol has to be used, not going for a non-cardiac selective beta. So here the diabetes and hypertension, you have to manage RAS inhibitions or immunoactivations, everything can be done. And oxidative stress, everything joins stand to produce more events. So how is the dyslipidemia management? Lipid Association of India has clearly incorporated, is much more advanced than the Western population. They have categorized extreme risk, which is not seen in abroad. Sir well knows, one of the pointers is sitting here, is those extreme risk category was introduced because we people are having high risk of CV events, repeated CV events at a younger age. So Western guidelines says you target the LDL less than 55. If you have high risk events, repeated CV events, you can even target LDL less than 30 was guidelines categorized B. So for these you require, many of the goals by Western population is less than 50% reduction from the major level or target the LDL less than 55. But Lipid Association recommends high risk patients less than 55, very high risk, even pull the LDL to the lower level of less than 30. For that we have to use high intensity statins, should be the goal of the individuals. If you are not able to achieve the LDL of less than 50 or less than 35, you can introduce the statin as the main course therapy. If you are not able to achieve or if there is any intolerance to the statin, you can invite estimab or bempedoic acid, your injectable PCSK9 inhibitors, but target has to be reached as early as possible if you want to avoid next event for the individuals. So these are the ESC guidelines. We have much more cross then. And antiplatelet therapy, routine antiplatelet therapy for all diabetic individuals is not beneficial. Starting aspirin for all diabetic individuals or clopidogrel for all diabetic individuals is not beneficial. They have been clearly extrapolated. You are going to increase the bleeding risk for the individuals. So how are the people are any calcium score positivity, recovering high intensity statin, any other vascular events for the individuals, patient having any peripheral vascular disease or any history of stroke or TAA, or you can put the patient on single antiplatelet, don't go for a dual antiplatelet therapy because even post PCI, after 2 years, 3 years, we are down regulating to single antiplatelet. Many of the prescriptions I see starting with patients who have any gold therapy, and many of the gold medications can statin, clopidogrel, aspirin, because many of the individuals may have some sort of bleeding diathesis, intracranial bleed, any of the people subjected to surgery, they will be roaming here and there for cardiologist opinion for all the times. So if you analyze the risk, bleeding risk is also there when you start antiplatelet therapy as the duration of the benefits. So benefit of therapy, of statin therapy also has a harbor of risk of bleeding. So choose the patient wisely to start aspirin therapy. Don't start for all the patients. Thank you for the patient listening. Sorry for taking much more time.
Thank you very much, sir. Wonderful presentation. Really done a justice for the topic. And started with the early detection and prevention of CAD. Yes, insisted one point that early detection of diabetes, tight control of diabetes, right from the beginning, no CAD. Wonderful points. And asymptomatic patient, you want to screen for CAD, only you do the markers, like endothelial markers, endothelial like a urinary albumin excretion. That's a marker for the CAD, not only the CKD, marker for CAD. And also those who are asymptomatic, you do coronary calcium scoring, not for asymptomatic individuals. So when you want to do coronary scarring, SCT angio, you do only for asymptomatic to assess the plaque burden and give high intensity statin to prevent the event. So wonderful point. And of course insisted on the early detection and a high statin dose for those who are vulnerable patients. Great learning from you, sir. Wonderful presentation.
Thank you,
and
sir.
I'll go to our chairperson, sir.
Thank you, Dr. Mahadan, for your excellent presentation. These calculations of CVD risk, okay, about 30, 40 years and above. Now diseases are occurring. Obesity is occurring at the age of 20. So what we should do, particularly for Westerners you have presented, what will happen in Indians, particularly when to start to screen for CVD risk before the onset of the disease?
So first good thing is when we get diabetes a decade earlier. Same thing, CV events is happening a decade earlier in India when compared to the Western populations. So any patients comes to a clinic have a holistic approach. So give weightage for the symptoms. Patients have any heart failure symptoms or angina symptoms, even peculiarly exertional breathlessness can be the presenting symptoms of any acute ACS. Though give weightage for the symptoms and give weightage for metabolic syndrome. Any parameters of metabolic syndrome is there. Any patient may have a fatty liver. Patient may have increased visceral adiposities. Many of the patients go for scanning now, understandings. And we will give more importance for high sensitive CRP. Even patient will come with high sensitive CRP after this COVID era. They will see what to do. So instead of going for that, check what is the BP level of the individuals. They will not give much weightage for taking antihypertensive therapy. They give much more weightage for the lipid segregations, not only total cholesterol, give weightage for the LDL. So if you add everything together, the patient having a futures of metabolic syndrome, the probability of CV events is very high. So, and you can adopt any risk factor. We don't have a well-designed risk factor here.
Before the onset of the disease, the population of developing diseases are moving from 40 years to 30 years, 20 years like that. That we have to assess. Should we have a common program for college students or those who have family history? That's what I want.
Family history, strong family history of premature cardiac vascular events, maybe death or MI or revascularization. Familial hyperlipidemia requires high intensity statin irrespective of the baseline diabetic or hypertension. It doesn't fall in the category. Patient have strong family history of documented familial hyperlipidemia or family history of strong CAD requires high intensity statin. That is the guideline says. Any diabetic individuals having high burden for CV events, maybe smoker, maybe high central obesities, maybe hypertension, better treat that event. We give much more focus on the risk factor modification than going for a CT angiogram or then going for some other high invasive modality screening. So give much more weightage for the screening than going for a sophisticated investigations.
Thank you very much, sir. Wonderful, sir. Thank you very much.
Thank you, sir. Now we move on to the next session. The speaker of this session, Dr. M. Navid Nasser, is a consultant nephrologist and renal transplant physician at Asian Institution Nephrology and Urology.
Thank you, sir. Welcome. I welcome Dr. Naveen, sir. So after listening to the early detection prevention of CAD, now we have Dr. Navinath to talk on prevention early diagnosis of CKD. CKD is yet another worst complication of diabetes and taking all the complications in the lead. So preventing the CKD is definitely saves a life. So thank you very much, sir. Stage is yours.
1 minute, doctor. CVD risk factors or CVD diseases are deadly complications. nephrology related or kidney related problems are costliest complications of diabetes. So what to do? Please proceed.
Thanks a lot, sir. So I'd first of all like to thank the D Club team for including me in this wonderful event. So I think actually I should compliment for the way in which they have structured the program also. So I should also actually thank my previous speaker. Whenever you club the kidney and the heart together, because most of the treatment for the heart is actually a treatment for the kidney as well. And most of the time when you want to treat the kidney, it's supposed to be sure that you don't injure or harm your heart. And as rightly the chairperson said, so whenever you look at the heart, you should look at the kidney as well. And whenever you look at the kidney, you should look at the heart as well. So what I mean to say is, my talk is going to be almost a supplement or complement to what my previous speaker had said. Many times I'm going to repeat what he said, so my work has become very, very easy. So I hopefully finish the talk within 10-12 minutes. So let's go to the first slide. And the first slide is always, I start by thanking my alma mater. So I am what I am because of my teachers from these two great institutions, Madurai Medical College and All India Institute of Medical Sciences, New Delhi. And so the first slide. So a very simple slide on how do you diagnose a kidney disease early. I think the easiest disease, organ damage which you can diagnose in an early stage is actually the kidney. All you need is a blood test and a urine test. That's all. You don't need big imaging or like what sir was saying, like calcium score or angiography. None of those things are necessary. Very simple OPD based investigations which all of your patients can easily afford. So whenever a patient with diabetes comes to you, I'm sure all of you are looking at the FBS, the PPBS and the HbA1c. Please don't forget to add the urea creatinine and the urine routine as well. What do you find from this? Don't stop at creatinine. Please measure the EGFR. All of us have a smartphone nowadays. You just need an app. You need to just log in 3 things: the age, the sex, and the creatinine. You get a number. Now, why is this important? Because we all have this notion that a creatinine of less than 1 is normal, so the kidney is functioning fine. But if you see the relationship between EGFR and creatinine, it's not a linear relationship. If you see over there in the second picture, for a rise in creatinine from 1 to 2, the fall in EGFR is quite significant. So after 2, if the creatinine is going to rise, the EGFR does not change much. So most of the treatments which we have for prevention of or preventing the progression of CKD should be done at a much earlier stage than once your creatinine has already touched the level of 3 or 4. So that is why calculation of EGFR is very important. A creatinine of 1 for a gentleman of around 75 years might not be normal. So please understand this thing. And the next thing is the urine. A very, very simple test. You have to measure the proteinuria. So like what my previous speaker had again said, whenever you look at proteinuria, it is a marker of endothelial dysfunction, not just the renal endothelium, but also the coronary. So the other picture over here, that's what I was saying, the kidney and the heart are the best of the friends. So whenever you are having a CKD, the patient is a very high risk of a coronary artery disease as well. And the chance of a CKD patient dying of a coronary artery disease is actually higher than him developing an end-stage renal disease. So that's why it's very, very important in trying to pick up early kidney damage. And this staging and all those things, I'm sure all of you all know about what is stage 1, 2 and up to 5. And the last picture is again very important, risk stratification. So even if a patient is having a normal creatinine, if he is having significant proteinuria or a macroalbuminuria, they are at a higher risk for progression of renal disease. So that's why this red denomination. So they will need more frequent follow-ups so that you treat them appropriately. So jumping to the important part which I'm sure all of you all want to listen to. So how do you manage a kidney disease? So how do you manage early CKD? So as sir rightly said, it's a costly problem. Why a costly problem? Because you don't want your patient to go into an end-stage renal disease. Once they go into an end-stage renal disease, you don't have much other things other than renal replacement therapy, which I do agree is quite costly at times. So how to prevent this? So I have divided this into 4 main pillars. The most important thing would be glycemic control, about which we have been talking from the morning. The most important thing, I'm sure you're all experts at that. Maybe I'll add a few caveats to that. The second most important pillar is blood pressure control, equally important. My previous speaker had again talked about this, what drugs to use, and a few newer agents about which we are very positive. To be very honest, we nephrologists are actually poor people because for the past 20 years, we didn't have any great drugs. We were always saying, do the same thing, that is glycemic control, BP control, that's all we had. But now, we do have some good drugs. So I would try to talk about those drugs. And obviously, the most important thing, the thing which is many times overlooked, lifestyle changes. The most important thing, other than all the medications which we give, the thing which can really bring about a huge change is actually the lifestyle changes. Never forget about that. So coming to glycemic control, I'm sure you all know about the numbers, the trials, all those things are given over there. All of us know a good glycemic control where the HbA1c needs to be around 7%. And this, again, the number differs based on various criteria. If the patient is having CKD or comorbidity or the age or the risk of hypoglycemia, etc. And based on this, the number might change. But the bottom line is you need a very good glycemic control if you want to prevent any microvascular complications, and one such microvascular complication is diabetic nephropathy. And I'm sure all of you all know about the trials. I'm not going to go into the trials. So I want to make a mention about the usage of OHA in patients with renal dysfunction. So this is a common problem which we face. So what happens many times is, many times the treating physicians ask the patient to do urea creatinine and all those things, but somehow they just do the sugar, and that too they do at home capillary blood sugar, they don't do the blood investigations. And somehow monitoring of renal function becomes a problem for these patients. So one clue where you can find that the patient is developing some renal dysfunction is if your patient with bad control suddenly has good glycemic control, or your patient with good glycemic control suddenly develops multiple episodes of hypoglycemia. Always think of renal dysfunction. Why? Many of these patients might be on a long-acting sulfonylurea, which has to be excreted through the kidney. If your kidney is not going to function, these drugs tend to accumulate and produce multiple episodes of hypoglycemia. So what do I mean by this? Any patients with renal dysfunction, avoid any long-acting sulfonylurea. Avoid glimepiride and all those drugs. Try, if at all you have to give sulfonylurea, because they are the cheapest drugs, many times that's what we'll have to give. Please give them short-acting sulfonylureas like glipizide or gliclazide. Avoid all long-acting sulfonylureas. If the patient is able to afford a DPP-4 inhibitor, always we would prefer linagliptin because it does not need any renal dose modification. Other DPP-4 inhibitors need some amount of dose modification, but if your patient is able to afford a linagliptin, always go for that. Again, TZDs are very good drugs. They don't need any renal dose modification, but if your patient is having some cardiac risk factor, they are at a very high risk for volume overload. So if the patient is having CVD, please try to avoid glitazones in these patients. So the other categories I'll be talking in the next thing. So I think there was a breakfast symposium. So how many of you all had attended that? So again I said that's why the organizers have done a very, very good job. So the wonder drug which we have got right now is actually the GLP-1 RA. And I think you've already had an entire session on GLP-1 RA. So I'll just try to mention a few things. So the important problem with GLP-1 RA was that it was an injectable drug and it was very costly. It's almost the rage in the Western countries right now. The manufacturer Novo Nordisk has a GDP bigger than Denmark's GDP. So that's how successful this drug Ozempic has become. So mainly this drug is being used as an off-label for weight reduction, but basically it was introduced for management of diabetes, and I'm sure you know what it means. It is basically an incretin. So when you take food, there are certain gut hormones which get released which stimulate insulin secretion in your body. So that's how the GLP-1 RA functions. Now we have an oral drug which is semaglutide, which is orally you can take, and the patients are much more, it's easier for the patients to take. And this drug, actually it's a very good drug. It not only is important in glycemic control, but it is really helpful in reducing the patient's weight. So I don't know how many of you all have used this drug. I've been using this drug regularly for the past at least 6 months to 1 year now. And it is a beautiful drug. You won't believe the patients will lose some 10 to 12 kilos of weight within 3 to 4 months. The only biggest problem is the cost. It is quite costly. A 3 mg tablet costs somewhere around 300 rupees. So it is not a cheap drug. But if your patient is able to afford, it is really a good drug. So it acts mostly by decreasing your appetite, and it has certain specific instructions. It needs to be given first thing in the morning with a very small amount of water. The one thing you have to always ask the patient is if there any family history of a medullary carcinoma of thyroid. If so, it should not be prescribed. There is some theoretical risk of pancreatitis, but at least I have not seen it very commonly. But if the other beautiful thing is, many of the drugs which we have cannot be given for patients with a slightly advanced form of the CKD. Let us say the GFR is between some 20 or 15. Most of the drugs you give have to be stopped. But this drug can be given at a lower GFR. Even at 15 or 20 GFR, you can give this drug. So it is really a beautiful drug. So I would suggest you to use it if the patient is affordable. Yeah. So this is the data which I was talking about. This is the flow trial which had come. And now there's also one more drug which we are all very excited about. It's called the tirzepatide, which is actually a twin incretin. So it is not only a GLP-1 RA, but also acts on the GIP, which is the other incretin. And there's again a trial which is ongoing called the SURMOUNT trial, which we are all awaiting the results of. And hopefully it will be another drug in our armamentarium to reduce the risk of renal dysfunction. SGLT2 inhibitor, I'm sure now with every diabetic meeting really talking about SGLT2 inhibitors. So we had one case even previously where even almost a type 1 diabetic patient was being given an SGLT2 inhibitor. So that's how popular this drug has become. So I'll try to play the devil's advocate over here. It is a beautiful drug, no doubt. If your patient is doing well, otherwise fine, please give the drug because it prevents renal function worsening. It's extremely good for patients with heart failure, no doubt. But we do see quite a few patients coming to us with urinary tract infections. Now, it acts by glycosuria, isn't it? So if your patient is going to be having glycosuria, they are going to be at a high risk for urinary tract infection. Being a single specialty hospital, we have seen multiple cases of atypical UTIs, patients having fungal UTIs, and recurrent urinary tract infections. And most of these patients would be on dapagliflozin. Once we stop the drug, many of these UTIs are easily managed and they stop getting recurrent UTI. Yeah, it is a beautiful drug, but do tell your patients if they have dysuria to come back to you, and maybe you'll have to stop the drug temporarily at least till you are able to manage the UTI part of it. So this is a beautiful Venn diagram where it says about everything. So this is taken from the KDIGO guidelines. So I'm sure it's very, very useful for all the diabetologists. So which drug is preferred and which drug is not preferred based on what you want to look at. So let's say if the patient is having heart failure, you would prefer a GLP-1 RA and you would not give a thiazolidine. So I'll try to give you the slides so you can go through that. So it's a very, very beautiful diagram which says what you would prefer. And what is in the left is how you start a treatment. So metformin is not automatically contraindicated in every patient with chronic kidney disease. Only if your EGFR is very low, you would not prefer to give. Otherwise, you can give metformin. It's a cheap drug and it's a very good drug. And please understand, SGLT2 inhibitor is now a first-line drug. And the second-line preferred agent is actually a GLP-1 RA. So all the other drugs like the sulfonylurea or insulin, all of them have gone down. But again, I do understand the cost is a problem. If cost is not a problem, we would always prefer for patients with early CKD to go on with a metformin, SGLT2 inhibitor and a GLP-1 RA if possible. So BP management and chronic kidney disease, again, very, very important. Easily diagnosed condition, all you have to do is look at the blood pressure of the patient. And if the blood pressure is high, we would always want it to be controlled. The targets is very simple, less than 130/80, and as low as possible if the patient is having macroalbuminuria or proteinuria. So the lower the better. So we have so many trials. Again, the sprint trial, even if you go to 100, if the patient has no symptoms, the trial says it's good. So lower the better, but be very careful if the patient is having symptoms, and be very careful, especially in the elderly population. If your patients are more than 70 or 80, a very low BP, they might not be able to tolerate, so be very careful. And what is the preferred agent? So my previous speaker had again spoken about this. If at all you want to give one drug in a patient with diabetic CKD and proteinuria, it would always be AC inhibitor and ARB, and try to uptitrate the dose to the maximum possible dose. But whenever I say AC inhibitor, ARB, the immediate next question the audience should be asking me is, the biggest problem is always potassium. So if you're going to be giving AC inhibitor and ARB, never forget to monitor the patient's potassium, especially if the patient is having renal dysfunction, because most of our patients, they are all very fond of tender coconut water, fruit juices, and if they're going to be taking a high potassium diet, having renal dysfunction, you give them AC inhibitor ARB, they're all going to land up with hyperkalemia, and that can result in lots of cardiac problems. So always when you're prescribing AC inhibitor or ARB, advise your patients they should be on a low potassium diet and monitor the potassium quite frequently and monitor their renal functions as well. So that's what this flowchart is all about. So the other drug which we are all very upbeat about, or the drug which we feel is really very helpful. So I mean, many of our seniors, actually they were all using a drug called as spironolactone, right? So it was basically a mineralocorticoid receptor antagonist. So again, even now it's for a poor man, maybe we can prescribe that drug. But this drug, it's actually a mineralocorticoid receptor antagonist. It's finerenone. It is a non-steroidal molecule, and its effects are much better, especially for a diabetic CKD with proteinuria. This drug does prevent development or worsening of renal function. And we have, again, umpteen number of trials. We have the trial called as the Figaro, the Fidelio. Again, they were all based on cardiac outcomes. The subgroup analysis for renal function outcomes are also very, very pro. The other problem, again, is the cost. So this is also quite a costly drug. It comes by the name of Kerendia from Bayer, and from Sun they have Livelsa. It costs somewhere around 100-120 rupees. But if you can prevent the patient from going into an end-stage renal disease, I think it's all worth it. The other problem, I told you, whenever you give ACE inhibitor IRB, the problem is potassium, and now when you add a mineralocorticoid receptor antagonist, you are going to compound that problem. Because it again acts on the RAS system, the chance of getting hyperkalemia is higher when you give both the drugs together, so be very careful about potassium, never forget that. So the other thing which I often get asked about is diet and CKD. So the moment the patient is having CKD, they come to me, sir, they have told not to eat anything, sir. No salt, no protein, no nothing, no meat, don't eat anything, don't take dal. Then, I mean, at last the patient is left with nothing, isn't it? So that's not the point. The point is to go down on a low protein. It doesn't mean zero protein. None of our patients, actually if we come to the, see, most of these guidelines are based on the Western standards, where people eat steak, that is a blob of meat. In our place, if you ask them to take non-veg, they take maybe, even if they take a chicken biryani, it's more of rice with 1 or 2 pieces of chicken. It's more of gravy with 1 or 2 pieces of meat. So actually our diet is not very protein rich or not very animal protein rich. So once a week, 2 pieces of meat should really not be a problem. Fish is actually not a problem. Egg is usually not a problem. Daily intake of too much of meat might be a problem, so that you should avoid. Plant proteins are actually not a big problem. Patients can take. The problem which we face is malnutrition. Once the patient goes for such a low protein diet and low salt diet, what happens is they stop taking anything, they lose all their muscle mass, and they become much sicker. So no point in trying to have a lower creatinine at the cost of losing the patient. So be very careful when you prescribe the diet to the patient, and take the help of a good dietitian. It really helps in a very big way. So this I said, I did wanted to put one slide at least on lifestyle changes and in diabetic kidney disease, because actually this is the most important slide, to be very honest. More important than talking about all the drugs which we had talked about, the one thing which can really make a change is to ask them to improve their lifestyle. Okay, good physical activity, proper dietary changes really goes a long way in bringing about a change. And never forget to talk about the heart. Very, very important. Stop smoking. The patient will listen if the doctor says. They will never listen if their friends or the attenders say. But if you insist, many patients do stop smoking. So always ask about the history of smoking and tell them stopping smoking really helps. And obviously the other things which we have already talked about, statins and lipid management and all those things we have said, and how to give antiplatelets, we have already talked about that. And one more slide on drugs and CKD. Now this is another very, very, very important problem, because see, as physicians, you are the people who manage most of these patients, and they have multiple problems. Kidney is just one problem. They'll be having diabetic neuropathy, and you will be giving them gabapentin. Let us say his creatinine is 3. The dose of gabapentin you should be giving him should be much lower. You give him the gabapentin dose for like a normal renal function, he's going to be in trouble. So always prescribe drugs after looking at the GFR. And contrast and kidney disease, again a major issue. So if the patient is having renal dysfunction and the patient needs a coronary angio, it will depend on the situation. If it is an acute MI, no point in thinking about the kidney, you have to save the patient, so you go ahead. But if the angio can be avoided, we would always prescribe you avoid it, and try to avoid all nephrotoxics, predominantly the NSAIDs and certain other agents which we would like you to avoid. But otherwise, you should be fine. So always, if the patient is having diabetes, before prescribing drugs, just think about the kidney functions as well. So I think this is my last before slide, so I'll finish it off. So just a summary of whatever I had said. Maybe it's a bit small. Whatever I said, so it's very simple. A patient with diabetes comes to you always, for the kidney, just do a few blood tests and urine tests. If he has a kidney problem, keep him in regular follow-up and give him the 3 medications which I've really talked about. SGLT2 inhibitors, GLP-1RA and finerenone. The rest is always going to be there. That is the ACE inhibitors for blood pressure management and good diabetic control with whatever OHA and insulin as necessary for the patient. And this is the take-home points. Obviously, the role of the physician is paramount. Manage diabetes, hypertension, and the cardiovascular risk factors. The heart and the kidney is always a good friend. So taking care of the kidney is almost similar to taking care of your heart. Monitor eGFR. I have not written creatinine. I have said eGFR. Look at the ACR and PCR. Consider these 3 drugs. We are your friends, so you can always take our help whenever you need to manage your patients. And try to avoid unnecessary drugs and modify the dose of the drugs you give for a patient in CKD. Thank you.
Thank you very much, sir, for a brilliant presentation. It's really an encapsulated summary of diabetes and nephropathy and kidney disease and to the lot complication. So wonderful. You started with what sulfonylureas can be used, short-acting sulfonylureas. What DP4 can be used, linagliptin. What GLP, the use of GLP-1RA wonderful effect on the kidney disease. And two molecules that decrease the intraglomerular pressure. One, this SGLT inhibitor, two ACE-ARBs. So this combination. But this should be used judiciously. And also at another molecule, that is mineralocorticoid receptor agonist, phenylenone. So wonderful, brilliant presentation. Regarding the salt is concerned, so we say 2 grams salt, 3 grams salt, but we can't be measuring salt. How to know? We would take a spoon, very difficult. But I was searching for how to make it simple. 4 pinches of salt, that is equal to 1 gram of salt. You prepare food without salt. Put 4 pinches, that is equal to 1 gram. If you want to 2 grams, 8 pinches. That's all. You need to measure with the measuring things. So that's an easy thing. A really brilliant presentation. Is a very much eye opener for all of you, sir. Thank you very much, sir. Now I'll give to Professor.
I think we will go for a discussion and then we'll finally tell something. Any questions?
Most of the nephrology contraindicate angiocholitis because it causes abortion. Does it not fetal anomaly or actual abortion?
Sir, can you repeat the question? I didn't get the first part.
Pregnancy.
Yes, sir. Yes, sir.
It's contraindicated pregnancy.
Yes, sir. Yes, sir.
Does it cause congenital anomaly or abortion itself?
Basically, it can cause congenital anomalies, sir. So it's basically not to be given in the first trimester. So if you have a young female who is planning for pregnancy, better not to put them on ACE inhibitor or ARB. Because most of the issues will come during the first trimester, and unfortunately during the organogenesis phase the patient might not even know that they are pregnant. So even if they are planning for a family, you will not be able to give an ACE inhibitor or an ARB.
Sir, one point regarding the angiotensin, sir. Angiotensin is the one which is important for tissue growth, multiplication of tissue development. If you give blocker in the fetus is growing, the fetus will not grow. The commonest receptors are the more common receptors in the kidney. So kidney aging is very common. So it is a mutogenic hormone, this angiotensin 2. When you block it, it decreases the growth. That's the reason why is contraindicated.
Yes, sir.
Yes. Thank you, sir.
Thank you, sir. Now, I request Professor Dr. P. Parandaman, sir, to present the memento to Professor Dr. A. Sundaram, sir.
Just a minute. Thank you for your good lecture. Practical points you have told. The one thing that we'll have to remember is when you check for a diabetic, look for CVD and renal profile as both of them said. But you need not worry about the costly disease. But the man is going to die of cardiovascular disease, that's arrhythmia and other things. Thank you.
Thank you, sir.
Dr. A. Sundaram sir to present the memento to Dr. Mahadevan sir and Dr. M. Navinathan sir. Sir, now we move on to the next session, panel discussion. We would love to have the moderators and panelists of this session on stage. Professor Dr. S. Venkatramanan sir, panelists of this section, Professor Dr. C.R. Anand Moses sir and Dr. G. Vijay Kumar sir. Dr. Anand Moses sir, former Director and HOD, Institution of Diabetology, Madras Medical College, Chennai. Dr. G. Vijay Kumar sir, Apollo Hospital, Diabetologist, Medicare, Chennai. Dr. Professor S. Venkatramanan sir is a Senior Consultant Diabetologist, Apollo Hospital, Chennai.
Have you loaded the slides? Okay. So good afternoon. I think again it's a pleasant job to do a job with my two great friends, which we have titled as preferential positioning of the molecules. And I think the last two lectures, most of them have been covered from the point of view of the diseases. What we thought was we'll initiate a discussion so that we re-emphasize the points that have emanated in the last, say, couple of 1.5 decades, or more specifically in the last 1 year, with respect to some preferential positioning of the molecules. We'll confine ourselves to few molecules, mostly molecules which have been tested from the point of view of the metabolic endpoint, which subsequently have been proven to have convincing and consistent hardcore endpoints with respect to heart failure, CKD, and cardiovascular disease. I think we have had paradigm shifts with respect to the positioning of the various drugs. I'm sure Professor Hariharan, Professor Narsingan, and Professor Sundaram are there, and of course Madhu was there, Anand Moses is there. We have all witnessed the changes. So gone are those days wherein you used to harp only on lifestyle modification as the only intervention. So drug therapy at the time of diagnosis was viewed something like a taboo. So just to start the discussion, I think I would like to view the views of Professor Anand Moses and Professor JVK. I call him Professor because he professes a lot. So the two people. Now, why I am talking about this molecule is, now metformin has been in use. For some of you may not be knowing that, we come from an institution, Madras Medical College, all of us, Professor Hariharan, Sundaram, myself, and Madhu, and of course Anand was also there. When the whole world was against metformin, or most of the world, we continued with metformin because if you stop the biguanide, we knew the ramifications. So subsequently, after the UKPDS, everybody said, oh, it's a brilliant drug, it addresses insulin resistance, so it should be the first drug. Now, having said that, there are some people who believe that the recommendation of metformin, advocacy of metformin, was based on a very, very small number of people in the UKPDS. Number one. Number two, if somebody who has got probably a mild diabetes, who has had a cardiovascular event or heart failure, if the glycemic capture could be undertaken with just an SGLT2 inhibitor, do we need to compulsorily introduce metformin in such a scenario? In other words, there are schools of thought which do believe that you need not confine yourself to the age-old custom of starting every patient on metformin. So what are your views on that, Professor Anand and Professor GVK?
It's a very important question, sir. Actually, you have thrown one controversial or debatable question whether he has to go for SGLT inhibitor or metformin. When you come to the cardiovascular benefit concern, cardiovascular benefit is concerned, whether you give it with SGLT2 with metformin combination or SGLT alone you give, both are same. There is no difference in cardiovascular benefit is concerned. But whereas if you look into the glycemic control, which is also an important part of or integral part of it, I would rather like to go for a combination with metformin rather than going for SGLT alone. I mean, it works better. Probably SGLT has got a reduction in lipotoxicity, glucotoxicity, insulin resistance, everything. But still, I think hepatic glucose output wise, no one can match the metformin. Of course, SGLT inhibitors also reduce the fat in the liver, and then we will reduce hepatic glucose output. For glycemic control, both. For you want to have only for cardiovascular benefit, only SGLT inhibitor, no need for metformin.
I think metformin is one of the oldest drugs. It finds as a first line in all the guidelines. With a certain reason, we all know type 2 diabetes predominantly is insulin resistance at the early stage, and most of our Indian diabetics whom we thought were non-obese, Professor Hariharan will agree with me, many of them are obese even in the lower socioeconomic class. We have done a number of studies on that, and I think metformin forms the basic drug. It should not be, it's a cheap drug, it addresses insulin resistance, it addresses body weight, so whatever combination you may use, unless there is a contraindication for metformin or intolerance to metformin, it should be a first line drug.
Can I ask a question? Both of you senior people can answer this. Sir. That is it possible for us to have a very good control without metformin? Unless it is contraindicated. It's a very tough thing, sir, actually. With metformin only we can get a better control of diabetes. You agree with me, sir?
Yes. The slide is, right. Now, I think the consensus was certainly metformin has enjoyed the reputation, a justifiable reputation of being the number one drug. So, all the guidelines used to capture lifestyle with metformin as the first line from the metabolic point of view, and of course, we do have evidences that probably it does have an effect on the cardiovascular, and of course, our portfolio has really been enriched with the advent of new molecules which do have a disease-modifying potential with respect to heart failure, hospitalization or CV death or the CKD progression which we have listened. Now, having said that, I think here we'll spend some time. Now, when you start with therapy, monotherapy has been the slogan advocated by the various guidelines. Now, somebody with a HbA1c of 6.9, 7.1, I think we were quite reluctant to even talk about combination therapy. I think as nicely pointed out by Dr. GVK, if monotherapy, metformin is such a robust drug, it can reduce the HbA1c. Even from 7.3, it can push you to about less than 6.5. In this scenario, the AACE guideline was one of the earliest to harp on combination therapy. I think if the HbA1c cutoff was more than 7.5. Now, in the result of the VERIFY trial, wherein in the early part of the disease, very early drug-naive patients, the VERIFY trial proved that starting on combination therapy is superior to monotherapy because it prevented drug failure, which was defined as 2 successive HbA1c at 3 months apart exceeding 7%. This was a huge trial. I think one of the eye-opener for subsequently the various guidelines to recommend combination therapy as the first prescription. Of course, this was done with vildagliptin and metformin. So in the background of, and to remind you, the baseline HbA1c of 6.9. So with a 6.9, to talk about a combination therapy, I think from the clinical standpoint of our own experience, we would have been slightly reluctant, and there were no increased risk of hypoglycemia. On the other hand, you had some exploratory evidence to suggest that this strategy probably preserved the beta cell function. The drug failure was postponed significantly to the tune of 50% compared to monotherapy. So in this context, with the VERIFY trial, do you think, Professor Moses and GVK, that combination therapy should be the slogan for all type 2 diabetic subjects?
I think VERIFY trial, I think it's really changed the way we treat diabetes. Although in the Indian context, we were already using combination right from the beginning. Most of us have the habit of using 2-drug combination, but without much of evidence. For the simple fact, diabetes is a disease of two. One is insulin secretory defect, one is insulin resistance. So unless we address both together, we may not get good glycemic control. That is the reason why we're using. But the VERIFY trial was a wonderful trial because they introduced combination with a HbA1c of less than 7. People less than 7, where we would be reluctant to use a combination therapy. They have used combination therapy, and they have shown that it preserves the beta cell, and the duration of drug failure is prolonged. I think that was the message from VERIFY trial, where irrespective of, if you look at even now the American guidelines, it says the dual therapy, multiple therapy after 8, I think. After 8, above 8 you go for a dual therapy. I think this has changed the way, and we have already been practicing this, and we should continue to practice with the evidence from the VERIFY trial, a combination of metformin and any other secretagogue.
Just add to what Sir has said is that only about 2 years ago, I think all the guidelines like EASD, ADA guidelines, everyone said for combination therapy. Prior to that, if you could see that, they used to say that lifestyle modification, metformin. If it fails, you put one more drug. If it fails, you put one more drug. If it fails, start insulin. So if you could see that in all through the years, what has been almost about 15-20 years, the guidelines have been on a failure mode. Only when you fail, you go for a combination therapy. Now I think the trend is changed. even before verified trial has come. I think addressing the whole thing is that philosophy of management is not now treating hyperglycemia, rather treating the pathophysiological factors that cause hyperglycemia. In that way, addressing as many pathophysiological factors in the woman's octet, what we call, is a very, very essential thing. That is number one. Apart from Dr. Moses has said that, you said, sir, is that verified trial, it is more, the 300 and odd patients are from India, they did much better than Caucasian population. The duration, were going for a combination therapy, where they had to have a rescue therapy is about 2.5 years in other population, it is 4.5 years in Indian population. So I think the combination going for DPP for metformin is more reasonable for Indian population apart from global population.
Thank you, Vijay. I think the message is loud and clear. Now, in the verified trial, the messages have been alluded to, have been nicely discussed. Some of us who might be slightly pessimistic, if you can use the word, that why should I increase the therapeutic load? I can sequentially add a molecule. Lifestyle modification with metformin, when the HbA1c is not within the target after 6 months, I'll add vildagliptin or whatever molecule you want to. But the verified trial has given answer to even such pessimism. It is better than combination therapy at initiation of treatment is better than the sequential therapy. So combination therapy at diagnosis is better than monotherapy. Combination therapy is better than sequential addition of molecules. I think that's where we stand. I think the verified trial has given a lot of messages. So why we started with these two are, these I think are paradigm shifts in the management of diabetes. That is harping on therapeutic intervention right from the diagnosis and then be aggressive with respect to positioning of molecules with a dual drug rather than the conventional policy of sequential therapy. Start with one molecule, up titrate the dose and then add a second molecule. I think a lot has been discussed about in the context of the CVD and the CKD with respect to the SGLT2 inhibitors. To be very frank, I think we will just go back to the journey of these molecules in the last 1 decade. I always I fancy that discussion because I still remember empagliflozin by BI and then canagliflozin by Janssen and then DAPA by AstraZeneca were introduced, and all of them we were all part of many of the discussions which happened prior to the launch. Uniformly across the country, I'm sure throughout the world, everybody said this we view it with a lot of pessimism or apprehension because conventionally glycosuria is always been viewed as a villain in the context of diabetology literature, is it said? Whenever, even though we no longer depend on glycosuria either for diagnosis or for monitoring, glycosuria. So once we talk about glycosuria, that is facilitating the extra excretion of glucose in the urine, this mode of therapy, whether it will be first of all suitable for our Indian population, and if at all it is suitable, whether it will have a meaningful effect on the metabolic endpoints, and of course, surprisingly, we had consistent benefits with respect to the cardiovascular and renal endpoints. So how do you look at the journey of these molecules? In my opinion, they have been wonder drugs, as Braunwald put it, statins of this century. So what do you say?
Yeah,
Vijay and
the history,
Anand.
what you said, sir. In fact, when EMPIRIC outcome is the first one to come out with CVOT trial, in Stockholm, we were all there at the time in Sweden. Even though, when the results were, there was applause like anything. So they were not very sure why these benefits have been there, renal and cardiovascular benefit was there. They probably thought because of the STENO2 effect. There was a glycemic control, reduction in blood pressure, reduction in triglyceride and improvement in HDL. Probably the STENO effect is there. But later on only they found that the molecular benefits and then mitochondrial benefits and weight management, all those things have been there. So I think the journey I think in the last 10 years or so, I think the amount of work that has been done with SGLT inhibitors from every endpoint, like what you said, metabolic endpoints, renal endpoints, and cardiac endpoints has been extraordinary. If you look at the metabolic endpoints, I think you always fancy telling that the ectopic fat reduction is something extraordinary that happens with SGLT inhibitors. I'm not very sure whether that same thing happens. It happens with even GLP-1 receptor analogs, but it is major with SGLT inhibitors, I feel. And then renal endpoints, in fact, the EMPA kidney trial, which is the latest that has come, has shown that we can give it even to EGFR less than 20, up to 20 we can give. 15 or 20, sir? 15.
20.
Yeah. Up to 20 we can give. Prior to that, they used to say that only 30 or 40, but empiric has clearly said. And history-wise, if you say that, in those days, what we say that if the EGFR is less than 50, don't use SGLT inhibitor, because there is no glycemic benefit in those days. The history-wise. Now I think the more the studies that have been done as a renal endpoint is something extraordinary benefits have been shown. And of course, cardiac endpoints basically from CV death also towards the hospitalization heart failure, which contributes to the overall cardiac mortality. And that I think we got very good benefit.
I think a lot has been discussed about these points. Only thing I want to add is I think the message should be where you should not use this drug. I think the nephrologist has talked about it. Probably one of the, among the diabetic drugs, probably I wouldn't use the word misused, where I would say where it is being used where it should not be used. Particularly, I've seen it being used in patients very lean, very emaciated. I think this drug itself causes weight loss. Sometimes patients come to you with severe exhaustion and weight loss, unable to bear it. You must know when to stop it. And at least once in 2 or 3 months, I see a case of urosepsis with SGLT2. So when you use it, particularly in women, you have to be extremely careful. This can lead to very serious urosepsis, urinary infection and other problems. So you should be very careful in using the drug. And another most important thing is, if your patient is also consulting a cardiologist, see the cardiologist's prescription before.
Duplication.
Almost again every month I see double prescription. Patients taking 2 dapagliflozin, one from the cardiologist, one from the nephrologist, and one from the diabetologist. So they'll be taking 30 milligrams of DAPA. So if your patient is meeting a nephrologist and a cardiologist, check if there is a DAPA. So DAPA has come into all the 3 fields now. It's not a diabetologist drug. It has gone out of the hand of the diabetologist. So you have to be extremely careful when you prescribe SGLT2.
So no doubt, I think the sales of all the SGLT2 inhibitors are going up. I think this is probably one of the reasons. That's duplication and triplication.
No, one of the contraindications is social contraindication, as you said that, no, the way they lose weight and then, the buccal fat is gone, everything. A lot of people say, are you having any cancer or something like that? So that's a major thing. Sir, apart from that, sir, that, as he's already said, that in all the acute conditions, it is better to stop SGLT inhibitors. Definitely. We continue to see, even in these acute conditions, they're still continuing SGLT inhibitors. Especially when I'm practicing in cancer hospital, they continue to use that. So there was one study, I think with AstraZeneca, it's more of a real world study, about 5 years ago which came. The usefulness of SGLT inhibitors in ICU patient. Would you agree with that, sir? Because somehow I could not agree with that.
Yeah, I think if you know what you're doing, before that, what I thought, Vijay, when you talk about the SGLT2 inhibitors, yes, I think a lot has been talked quite justifiably from the point of view of cardiovascular, heart failure, CV death, renal endpoints. From the metabolic endpoint, you know how early these molecules start acting? Within 24 hours. They have done the CGMS, the time in range improves within 24 hours because they are not dependent upon the insulin secretion or the insulin action, mere glycosuria. So having said that, you are promoting glycosuria, as I started beginning. Is it a safe modality of intervention in a diabetic? Is it not? I think you promote glycosuria and you know that there is always an entity of renal disease and other problems. Of course, Anand nicely warned us about the risk of the UTI as well as, of course, the genital infections always, we are prepared for that, we know how to take care of it. So, coming back to the issue of glycosuria, can glycosuria by itself contribute to any adverse outcome? The answer is no, because we have the model of disease entity. I think again, thanks to Professor Hariharan, I learnt about it when I was in the department. There is an entity called familial renal glycosuria, autosomal recessive. If you do a GTT, it is very flat. You will have 82, 96, 80, fasting 1 hour, 2 hours, and glycosuria will be there in the fasting sample. So, but these individuals with familial renal glycosuria do not develop any major renal problem, number one. If it occurs very early, manifests very early, maybe in a very young children, it can be associated with some amount of growth retardation, excepting for that side effect. So this model of renal glycosuria has given the clinicians the confidence that you can use this modality of glycosuria as an intervention in diabetes from the metabolic endpoint. So you have a good reduction in the HbA1c, not dependent upon the insulin secretion or the insulin action, and you have the weight loss, and the weight loss predominantly as captured by the phase 3 trial data are in the adipose tissue. I think the warning signal which Professor Anand Moses nicely alluded to, if you have good amount of weight loss, then there are every chance, supposing you lose about 8 loss, it is not 7.5 kilos of adipose tissue, no, maybe 5 kilos, 5.5 kilos. So you are going to lose lean body mass as well, especially in individuals. That's one half of the story. The second step, it has been found to be effective for the for the cardiovascular as well as renal endpoints in the non-diabetic population also. So much so, I use the word the therapeutic space. Now, these molecules are being, the therapeutic space is shared by the nephrologist as well as by the cardiologist, quite justifiably in my opinion. So coming back to that, be guarded. When there is so much of a weight loss, at least there will be a cause for temporary withholding of the drug. Find out if there is so much of sarcopenia, do something for the protein content, maybe some amount of exercise training could be incorporated so that they regain some weight, and then still, if the compelling indication wants you to reintroduce, maybe introduce in a smaller dose and then monitor. So that point is very well taken. We have just tabulated, I'm sure, just a reminder for us, because we wanted to discuss some aspects of this wonder class of molecules, which in my opinion, excepting in cases of obstructive uropathy, wherein you look at the problem, it could be a simple tight prepucial skin, phimosis, or it could be a severe prostatic obstruction, or an obstructive calculus, anything. All these you take care of, and then think about introducing this molecule so that the endpoints are good. And initially we were worried about, even from the point for the issues in which they have been given. For example, when you use it in heart failure, how does it compare with the diuretics? Remarkable, remarkable. Because quite often, I'm sure Mahadevan will agree with me, it is probably from the mathematical modeling they have found out that it is the interstitial fluid that is preferentially lost, not much of a compromise of the intravascular volume, so that the sympathetic nervous system is not stimulated. And you have some mechanistic data to suggest that they do have an effect on the preferential parasympathetic. They do have a favorable effect on the autonomic nervous system as well. So much so, there are some small data to suggest that the vasovagal syncope resulting in sudden death, one of the reasons which have been identified in the cardiovascular terminology, which probably we as clinicians are not that familiar with, that has been found to be impacted. In other words, there is a plethora of advantages for this molecule, but when anything comes with certain amount of caution, this caution is with respect to identifying an underlying problem, and having experienced too much of it, too much of weight loss, probably the muscle mass needs to be taken care of. Anything else you would like to, before we go on to the other class of drugs? Because we are not concentrating on the cardiovascular, everything has been dealt so beautifully in the last two brilliant lectures by Dr. Mahadevan and by Dr. Mohan, so that anything else, otherwise we will go on to the next class of drugs. So we started from the metabolic, I am just highlighting the preferential positioning of the points which have relevance from the metabolic point of view in diabetes, which subsequently have been found to have other benefits as well with respect to beta cell preservation in the case of the VERIFY trial with the DP4 inhibitor and metformin, and SGLT2 with the non-glycemic endpoints. Are the slides moving? Yeah, I just tried because it's not going forward. Now it's, there is a lag time. They want us to discuss much more on pre-programmed by the organizers. So it's not going forward. Yeah. Incretin-based therapy. I think again, way back in 80s and 90s, when we were just in diabetology, we used to share this thought with our own colleagues and students. An ideal secretagogue should be capable of correcting the hyperglycemia substrate dependent, and then should address the hyperglucagonemia, should be available in the oral form, and thank you. So this was subserved, most of the caveats were subserved by the incretin-based therapy in the form of DPP4 inhibitors, which were possibly a viable alternative at some stage of the disease. They cannot replace the sulfonylureas. At least you can postpone the introduction of sulfonylureas thanks to these molecules. Then came the realization that the GLP-1 receptors are distributed ubiquitously. So targeting the GLP-1 receptors, which are ubiquitous, beyond the pancreas, in the CNS, in the GI tract, is associated with benefits much, much more than what we can normally achieve with the conventional molecules of sulfonylureas, metformin, and lifestyle modification, and that is the body weight. So whenever we talk about the GLP-1 receptor agonist, especially, and also the SGLT2, we talk about the composite endpoint: HbA1c reduction, weight reduction, and the durability. A word about these three aspects with respect to the GLP-1 receptor agonists.
Yes, sir. In fact, one of the indications for using GLP-1 receptor agonist is the weight reduction. Because if you look into the amount of overweight and obesity amongst diabetics, it's almost 85%. 85% of our diabetic patients are having either overweight or obesity, or even waist circumference increase. So I think as far as the weight reduction is concerned, this is one of the good drugs along with the SGLT inhibitor. Now the next question is whether about renal endpoints and cardiac. That's what you want to say, sir? Next one. Okay, I think the renal endpoints are good enough, and then the cardiac endpoints wise, you can see that the latest studies with semaglutide has been found is about, there is about 18% reduction in MACE has been found, 18% reduction, which is non-inferior to the placebo but not superior to the placebo. That is one thing. According to the what is that?
Top end results of the soul.
Pioneer 6. Pioneer 6, accordingly, we can see that that had happened. But as the renal end, of course, like SGLT inhibitors, even the reduction in blood pressure and a reduction in triglyceride. One of the good things compared to SGLT inhibitors with GLP-1 receptor analogs is that even the LDL comes down, whereas in SGLT inhibitors, slight increase in LDL will be there. That's the difference between that. But whereas the reduction in triglyceride is possible only also, but not as good as what we see with SGLT inhibitors. That is one point. And as far as the renal endpoints are concerned, I think more robust evidence with the SGLT inhibitors, there is definitely improvement in that. Definitely we can think about that. But the current trend, what we could see is that when you have an established type 2 diabetic with an established cardiovascular disease with CKD, combining GLP-1 receptor along with SGLT inhibitors may be the most reasonable way of looking into that, and that you get the additive effects as well, and then better preventive or arresting the progression is a possibility.
I think the only class of molecules which have had the reputation of a consistent cardiovascular benefits are the GLP-1 receptor agonists. Right from the leader trial with liraglutide, the rewind with the dulaglutide, and of course with SEMA, and of course the top end results have been. So consistent reduction with respect to, and if you look at the graph separating, it takes almost 1.5 years for the results. So it is tempting to speculate, of course with some sort of soft evidences as well. They are doing something for the natural history of the atherosclerotic process as well. That is number one. With respect to the renal endpoints, there are two things. The GLP-1 receptors are there in the distal renal tubule. So distal renal glycosuria is facilitated. That is responsible, probably one of the mechanisms for the reduction in the blood pressure, number one. And they are good anti-inflammatory drugs. So this could be, see, when we talk about the renal disease, conventionally we talk about the glycemic factor, the intraglomerular hypertension, and the hemodynamic factors, and of course the statins and other things which do give a helping hand. And inflammation is one aspect which was probably not, we didn't have the avenues to address it. Maybe the GLP-1 receptor agonists are having an effect on the renal endpoints, presumably because they are anti-inflammatory effect.
And the SOUL trial, sir, the SOUL trial.
Yeah, SOUL trial, the top end results you just shared in the morning.
18% reduction in MACE even in SOUL.
Can I have the pointer change, ma? Or even it's not changing here. So maybe if it has been programmed to, I want to go forward. Yeah. So, even though I said in the beginning it was the metabolic molecules that we are going to discuss, it was tempting not to talk about this preferential positioning of the molecule in the context of diabetic kidney disease, especially. Because there are two aspects with respect to this molecule from the point of view of understanding of the disease. When we talk about the SGLT2 inhibitors, I think we have a lot of data, the preliminary information to suggest that there is a pathophysiological basis, that is the messenger RNA for the SGLT2 transporters are hyperexpressed in diabetes. Why? I think it's a maladaptive mechanism. We do not know. Maybe it's a knee-jerk reaction by the body in the face of diabetes, which is a catabolic situation, which probably the CNS sees as a situation wherein it needs to do something, and the preliminary effect by the body is to conserve the substrates. So the SGLT2 transporters being hyperexpressed in the context of hyperglycemia looks very, very maladaptive, but this is probably the reason, and that's why we have had the success from the metabolic point of view and other endpoints as well with respect to addressing the hyperexpression or overexpression of the SGLT2. Like you have the overexpression of the SGLT2 transporters, you have overexpression of the mineralocorticoid receptors as well. Again, we do not know the, see, I always use this as inflammation is the key to survival. So whenever you have inflammation, the body perceives the situation as something abnormal, try to do something, and participation of inflammation. If you remember, I mean, I'm just going to the basics as allowed thinking. So we should have some meaningful explanation as to why the MRA, the mineral receptor should be hyperexpressed in the context of diabetes. Having realized that, we have an excellent drug in the form of Finerenone because it is non-steroidal and it targets preferentially the renal as well as the kidney tissue. In fact, I think Dr. Mohan nicely alluded to the two studies, the Fidelio and the Fiderio. One was with the cardiovascular endpoints and the renal endpoints were secondary and vice versa in the other, so that there was an analysis, the fidelity analysis which was pre-planned. What you mean is you have a molecule on hand specifically for diabetic renal disease, and then they have studied this molecule up to an EGFR of 25, and then of course hyperkalemia is there. The way it modulates, I think, especially the rate of decline in GFR, maybe we have started using it, we have got some knowledge about it, some hands-on experience, maybe in future we would like to share, but proteinuria improvement, in my opinion, it's remarkable, especially when they are on maximal dose of tolerated RAS blockers, control of hypertension. This molecule does a wonderful job. What is your take, Vijay and Professor Anand Moses?
According to the data with Figaro DKD, where as I said that it is also cardiovascular, CVOT type of a trial, what they found is that hospitalization for heart failure is remarkably reduced, about 80%, 18% reduction, and then also all-cause mortality and CV mortality are also reduced by about 10 to 14% reduction is being there according to Figaro DKD trial. I think apart from, as I said, that there's an anti-inflammatory effect like what we also see with the GLP-1 receptor analogs, the same anti-inflammatory effect we can see with the Finerenone. And I think there is, apart from renal benefit, cardiovascular benefit also has been established, I think, in that way. And one more thing, see, SGLT inhibitors and, I mean, in fact, usually I say that to the patients is that SGLT inhibitors, GLP receptors will prevent the disease, to certain extent reverse the disease. But this one will repair the disease, that's what I say that, because the inflammatory effect and the amount of results from proteinuria, macro to micro, micro to normal, and then even creatinine levels coming down with this drug is something extraordinary. Only thing is that potassium has to be taken care of, and if it is less than 5 only, we need to start, and we have to keep on monitoring, and then potassium, if it is going up, we need to stop the drug. That's the only thing that we need to do.
Yeah, I think why we are discussing about these molecules, about the preferential positioning is, prior to the advent of these molecules, we used to confine ourselves in the teaching sessions and practice also to the conventional wisdom of targeting the risk factors, multifactorial intervention. Glycemic targets, BP targets, of course now the weight has come, and your lipid targets and lifestyle modification. We did not have molecules which did have a preferential say in the natural progression of the diseases or the endpoints which we are always worried about. I think that was the purpose of discussing about these three molecules. I'm sure, see, when we talk about, for example, you have a surgical wound, or you are talking about the inflammation in that area happening, which is facilitating the repair. When you talk about inflammation in a disease state like diabetes, inflammation is there everywhere. Why I'm mentioning about this, it is probably the trials are there. This is going to be as much a cardiac drug as a renal drug, because it takes care of the inflammation also. In fact, the heart failure benefits with respect to this molecule, if I remember right, and the cardiovascular endpoints, which has been clubbed together and captured in the fidelity analysis, have been as good as the renal endpoints. So with this, I think, so the discussion has to continue. I'm not able to change. This is with respect to, yes, this has already been mentioned. We just thought we'll re-emphasize the point. So the purpose of today's discussion, especially elaborating on some molecules where, thank you so much, where when you talk about the SGLT2 inhibitors, I think we as, I would say, metabolic physicians, Professor MGP Moses terminology, metabolic physicians, we call them as physicians, diabetologists, endocrinologists, we are all metabolic physicians. So we have the confidence, but when it comes to molecule like finerenone, I think let us not reserve it only for the slow preferential use by the nephrologist, because this disease, this molecule has got the potential to modify the disease. The data are convincing, the guidelines have captured it. So that is the purpose of this. And of course, when it comes to a discussion like this, you know when to stop and where to stop and when not to initiate. Supposing you initiate a patient with an SGLT2 inhibitor when this EGFR is 48, if it is coming down, you can always decelerate the process. If it comes to 28, let us not be panicky, because we have got evidence that it has been initiated even when it is less than 20. And of course, metformin, lot has been told about the. So, friends, what we have done is just random thoughts and the preferential position of certain molecules, right from metformin and combination therapy at diagnosis. We are backed up by the verified trial data, and then we did discuss in some greater detail or a revision of ideas or exchange of ideas, which we have witnessed in the last 1 hour from the two presentations. We focused on the SGLT2, the GLP-1 receptor agonist, as well as the finerenone, and also ended up with the KDIGO guidelines. I hope this is a good revision for you, and probably some aspects which require some clarification was facilitated by our good panelists. Thank you so much, Dr. Vijay Kumar and Professor Anand Moses. Thanks a lot.
Thank you for excellent moderation.
Thank you, sir. Now I request Dr. Nadarajan sir to present the memento.
இங்கே வரலையே, இங்கே வராதா, அங்கே தான் வருமா? பாயிண்ட் அது சேஞ்ச் பண்ணுறது ஸ்லைடு. இங்கே ஒன்றுமே தெரியாதா? ஓகே. Good morning, everyone. We'll start.
I'll introduce. So our Professor S.R. Narasingan sir is a teacher for excellence. He is honored by, is going to conduct first time in the world, in India, is going to conduct a World Hypertensive Congress in March. So it's a great applause. We all of you to give a great applause to that. It's international conference. It's going to first time in India. So such a great person now is agreed to present over here and to give a lecture on lipidology. So welcome you, sir. Thank you very much for your presence.
Thank you, Dr. Parandaman. At the outset, I would like to thank the organizers of the D Club for giving me this opportunity to be with you this morning to talk on diabetic dyslipidemia, the goals for LDL, HDL, triglyceride, non-HDL, and ApoB, how to achieve these goals. Probably I need to quote two important guidelines. So one is from the RSSDI, which was published in International Journal of Diabetes in developing countries in the year 2022. The second one is the Lipid Association of India, where I'm associated, and we came out with the guidelines right from 2016, 20, 22 and 23 also. Particularly for the management of dyslipidemia in people with diabetes, we got it published in the Journal of Clinical Lipidology in the year 2022. The ICMR INDIAB study not only had given us the information about the prevalence of diabetes in our country, but is also giving a data with respect to the dyslipidemia. The dyslipidemia prevalence is about 81.2%. Going into the depth of the details of the dyslipidemia, there is a recent publication in the Indian Heart Journal which had evaluated the various types of dyslipidemia. Hypercholesterolemia is about 24%, hypertriglyceridemia is 32%, low HDL is about 67%, high LDL cholesterol is about 20%. If you look at this, probably it is the high triglyceride and the low HDL which attract your attention, which is commonly seen not only in general population but also in people with diabetes, starting from metabolic syndrome. With respect to the lipid abnormalities in patients with diabetes, in type 1 diabetes, if the glucose control is good, always the lipid profile is normal. In type 2 diabetes, normally the hypertriglyceridemia with the low HDL is the predominant one, but all the time we are tempted to say only two things: atherogenic dyslipidemia. Please remember, it is not the two things, it contains of four components. One is high triglyceride, number two is the low HDL, number three is a high proportion of small dense LDL cholesterol, and the fourth one is the increased ApoB content. When the glucose control in type 2 diabetic patients go out of control, probably you do get slight changes in the parameters. Increase in the triglyceride will be abnormally high, and in addition you also get an increase in the LDL cholesterol. Whenever you see patients with hypertriglyceridemia, you need to say that there is an elevation of levels of non-HDL cholesterol. In fact, way back 2003, when the National Cholesterol Education Program, when it published the guidelines, it also included the ATP3 guidelines, which started saying if someone has triglycerides of more than 200 milligrams, after controlling the LDL cholesterol, you need to concentrate only on non-HDL. I think we wasted our time many years, and in the recent past only people started showing interest in the field of non-HDL cholesterol. The small LDL particles go up, high LDL particle concentration is also high in those patients with hypertriglyceridemia. In fact, many studies have confirmed that the non-HDL cholesterol is greater predictor of cardiovascular risk than the LDL cholesterol. This is the common lipid profile which we normally ask. One is the total cholesterol, two triglycerides, the third one is the HDL cholesterol. If you have the total cholesterol and the HDL cholesterol, it's very easy to calculate the non-HDL cholesterol. You don't require any laboratory help. Total cholesterol minus HDL cholesterol, you get the value, and that is non-HDL cholesterol in milligrams. The remnant cholesterol, of course, some of us now started showing a lot of interest in this particular parameter because of the increased cardiovascular risk in those patients who had already suffered from cardiovascular events. The recurrence of events are occurring probably due to the remnant cholesterol's contribution. The lipoprotein little, we measure it now. It is available even in the city of Chennai. And normally it should be expressed as nanomoles if you go for the mass, but it is being expressed in milligrams. Time will change the parameters configuration later. What is non-ester cholesterol? If you have the apolipoprotein A with the HDL cholesterol, it is an anti-atherogenic. Remove that from the lipoproteins. All that is remaining is considered under the one label, and that is non-ester cholesterol, starting from LDL, IDL, VLDL remnants, chylomicron remnants, including lipoprotein little a. All those things are clubbed, and then we come across this particular entity called non-HDL if you remove the HDL cholesterol from the total cholesterol. Having seen this, I should tell you that the LDL cholesterol, if you concentrate on the LDL cholesterol, the cholesterol that is contained in LDL is not only because of LDL but also for the contribution by the lipoprotein little a. Number two, the non-HDL cholesterol actually measures the cholesterol content of all atherogenic lipoprotein particles. What is ApoB? ApoB is concentration, measures the number of all atherogenic lipoproteins or the particles. This slide gives you an emphasis on the role of LDL cholesterol. LDL cholesterol plays a pivotal role or the central role, not only in the initiation of atherosclerosis in the form of endothelial dysfunction, but progression of atherosclerosis ending in clinical cardiovascular events such as acute coronary syndrome or stroke events or any other form of ASCVD. There are a good number of evidences starting from molecular studies, biological information, and then you have the observational studies, epidemiological data which go to confirm the role played by LDL cholesterol. Mendelian randomization studies have clearly indicated, including the genetic analysis, again confirmed the role played by LDL cholesterol. For example, you take familial hypercholesterolemia, it is only the LDL cholesterol that is responsible for increasing the cardiovascular risk, including the death. The third one is the randomized control trials. I think if you have a robust evidence that is coming only from the randomized control trials, the more the reduction that was witnessed in those trials, not only in primary but also in the secondary prevention trials, by using the HMG coenzyme B reductase inhibitor statin, proved beyond doubt that you can reduce the LDL cholesterol, you get a benefit, not only in cardiovascular morbidity but also in mortality, thereby emphasizing and re-emphasizing the role played by the LDL cholesterol. Of course, the animal experiments also had confirmed the data that LDL cholesterol plays a pivotal role. So I think we should concentrate mainly on LDL all the time, not only in people without diabetes but also in people with diabetes. There are a good number of evidences. That's what I was trying to tell you, that the robust evidence comes from the randomized control trials as well as the meta-analysis. All these meta-analysis, starting from the first one, the 25 randomized control trials, the other one is the 49 trials, and then the 52 trials. I don't want to go into the depth of the details, but the huge number. Just look at the last one is about 327,000 patients who were recruited for the studies. They were all taken into account for the getting the results. If you are able to reduce 1 millimole of LDL cholesterol, that is equal to 38.7 milligrams of LDL, you do get the benefit of cardiovascular risk reduction by about 21%. That is amazing result. Not only that, even about 10% reduction in the all-cause mortality had been identified by using the HMG coenzyme reductase inhibitors or plus statin or plus PCSK9 inhibitor on the whole. So I think I have now given you the important information that LDL cholesterol is the one that is responsible for increasing the atherosclerotic cardiovascular disease, even in people with diabetes, that we need to concentrate only on LDL for the first time and then concentrate on the rest of the things. I think many of you probably are not asking for the non-fasting lipid profile. This has gained a lot of importance in the recent past. In Denmark, for the past 15 years or so, people have stopped using the fasting lipid profile. They ask only the non-fasting lipid profile. I think I should make it clear before I go for this. There is also a statement which was published by the European Atherosclerosis Society where fasting is not routinely required for determination of lipid profile. The other one, why should we go for a non-fasting lipid profile? The initial lipid profile testing in any patient becomes easy. For CV risk assessment, again it becomes easy. Patients admitted with an acute coronary syndrome, you don't ask them not to go for fasting to take the blood sample. Even children, it becomes easy. Suppose a patient says, I'm in a hurry to go to the my meeting, probably you need to take out the blood sample and ask for only the non-fasting lipid profile. In diabetic patients also it is true. In elderly patients and people who are on stable drug therapy. Blood sampling process actually becomes simplified for patients, clinicians, clinical labs and hospitals. It has been successfully used in population cohort studies as well as in randomized controlled trials which had used the statins. All these studies which we are now getting it, all those studies in the past were all using only the non-fasting sample and not the fasting samples. Increases the compliance of lipid lowering therapy and monitoring also. So when will you ask for the fasting lipid profile? In that case, I think there are two opinions, one from the RSSDA, the other one from the Lipid Association of India. We started saying that if triglyceride level is more than 400 milligram, ask for a fasting lipid profile or particularly the triglyceride. Whereas the RSSDA started telling that 440 is a cutoff value probably beyond which you should ask for a fasting lipid profile that has been recommended based on the recommendation given by the European Heart Journal in the year 2016. If a patient with a hypertriglyceridemia is regularly getting followed up in your clinic, I think you should ask for only fasting lipid profile. Or somebody who comes and sees you repeatedly for pancreatitis, I think it is mandatory that you should ask for only a fasting for triglyceride values. Additional laboratory tests required, for example, you want a fasting blood sugar value, of course you can draw the sample at one time for even for lipid profile, for the fasting lipid profile. How to assess the atherosclerotic cardiovascular risk? It is a very big task. In fact, we had started publishing it in 2016, again 20, again 22, again 23. 23 is the one that was published in the Journal of Clinical Lipidology, particularly focusing attention on the management of